Welcome everyone for the class on pain and sedation. So basically we'll be discussing about the anesthesia. Whenever we are talking about the anesthesia, the first thing comes in our mind is endotracheal intubation. When you are doing an endotracheal intubation, you have done an laryngoscope and you visualize the vocal cords. If you're visualizing this image or this image, that means you are stuck, you are in the difficulty, there is no way to progress further. You might not have the equipments available to make in front of neck access, or you might not be having enough skills to do in front of neck access. So you get stuck if you're getting this view or this view. That's why the recommendation is you go ahead and do an airway assessment before you intubate the patient if the time allows. If you have enough time, always do an airway assessment. First thing what we'll be looking at is Koch-Lehans classification. This is when you put an laryngoscope and you're trying to visualize the vocal cords. The structure what you're trying to visualize is the topmost structure, the leaf-like structure. This structure what I'm drawing here is known as epiglottitis. These are the nothing but vocal cords. The white color thing what you're seeing here, the white color thing what you're seeing here are known as vocal cords. This part what you're seeing here is known as arytenoids. Okay, these are the three structures what you need to remember. There is a classification. If grade 1 is there, it's a very easy intubation. You or me can easily intubate because you're visualizing the vocal cords. You have to just place the ET tube through the vocal cords. That's the best way to do it. So this is the grade 1 what you're having where you're completely visualizing the vocal cords. Here in grade 2, you're just partially visualizing the vocal cords. That is actually known as grade 2A. What is grade 2B? In grade 2B, you'll be able to visualize the epiglottis. You're able to visualize the arytenoids, but you're not able to visualize the vocal cords. You can see arytenoids. Here you can see the arytenoids can be visualized. The epiglottis can be visualized, but you're not visualizing the vocal cords. That is known as grade 2B. In grade 3, you're able to visualize only the epiglottis. In grade 4, you're not even able to visualize the epiglottis. You can't visualize epiglottis, you can't visualize vocal cords, you can't visualize arytenoids. So nothing can be visualized in grade 4. Grade 3 and grade 4 is very difficult to intubate. So what we do is we kind of do an airway assessment to predict if there is a difficult airway. If there is a difficult airway, suggested by an Lemon assessment, we tend to always involve the anesthetics who are the experts and have an difficult airway trolley ready with you. So when you are really trying to intubate, if something goes wrong, there is an expert to help you out. At the same time, you have a qualified person who can perform an front of neck access and you have the necessary equipments. So what is the airway assessment? Airway assessment done according to the mnemonic known as Lemon, where L stands for look, E stands for E stands for evaluate, M stands for Malampati score, O stands for obstructions, N stands for neck mobility. The first thing what we are seeing is the L, that is the look what you're looking out for. What are you looking out for? Look out for any facial hairs are present, any facial asymmetry is present, any high arch palate is present. The teeth, especially the incisor teeth, are larger than what you're expecting. Large tongue, macroglossia, what you're suspecting. Short and thick neck. These are the things what you're looking out for. In evaluate, you're doing an 3-3-2 rule. In first three, what you're doing is you'll ask the patient to open their mouth as wide as possible and try to place as many fingers as possible. If they are able to place three or more than three fingers, then it is a good mouth opening. If there is a good mouth opening, that means the glottic view will be good. Next thing is from the tip of the mentum to the hyoid bone, you're seeing how many fingers can fit in. If three or more fingers can fit in, that means it can easily accommodate the laryngoscope. So laryngoscopy will be easier. Then you'll be seeing how many fingers are accommodated from the base of the mandible. That is nothing but from the hyoid cartilage till the thyroid cartilage, or the hyoid bone till the thyroid cartilage, what you're looking at. Or it is also known as thyromental distance. This is known as mental. So the thyromental distance or the hyomental distance also you can call it as. Why is it important? If it can accommodate two fingers, then it is not very anterior. Okay, this is the esophagus you are having, and this is the trachea you are having. Trachea is not very anterior. The anterior the trachea is, the worst or the more difficult it is to intubate. So if it can accommodate two fingers or more than two fingers, then you can easily visualize, or it is not very anterior the trachea is, so you can easily intubate the patient. If it is less than two fingers, then it becomes difficult. Only one finger, then it becomes very difficult to intubate or visualize the vocal cords and intubate the patient. This is known as evaluate 3-3-2 rule. Next one is Malampati score. So lemon ELM we are in. So Malampati score. In Malampati score, you'll ask the patient to open their mouth and make a sound ah. Once they make a sound ah, you tend to see inside the mouth what are the structures you are able to visualize. If you are able to visualize entire uvula, then it is class 1. If you're just able to see the uvula, but the tip of the uvula you're not able to visualize, then class 2. The tip and the stem, only the base of the uvula you are able to visualize, then it is class 3. Uvula cannot be visualized at all, then it becomes class 4. Usually the exams, what they'll do, they'll give you a picture and ask you which class it is. So you need to aware what structures, what you need to look out for. Mainly you need to look out for in Malampati score is the uvula. Uvula completely visualized class 1. Tip is not visualized class 2. Only the base is visualized class 3. Uvula is not visualized at all class 4. This correlates very well with Koch-Mac-Lehman's classification. So class 1 goes with group A or class 1 of Koch-Lehman's classification. Same to class 4 here, where you're not visualizing the epiglottis or the vocal cords or the arytenoid at all. So similarly, this class will very closely correlate with the Koch-Lehman's classification. Next thing in the obstruction. What we are looking out for the obstruction. Is there any mass present or is there any structural abnormality present which can cause the obstruction to the airway? So the obstruction to the airway, what you are basically looking out for. For example, the tonsils, there is an abscess behind the tonsils. So peritonsillar abscess, it can cause obstruction of the airway. Epiglottitis, inflammation of the epiglottis can cause. Retropharyngeal abscess can cause it. Any trauma to the neck, a circumferential burn around the neck, any tumors in the neck, all can cause obstruction of the airway. If there is a suspected obstruction of the airway, then it becomes difficult to intubate. Neck mobility. Whenever you're trying to intubate the patients, you want it in an ideal position. The ideal position is known as sniffing position. I'll be talking more about sniffing position in coming up slides. So basically, you want the patient to hyperextend the neck and flex at this level and hyperextend at this level. That means hyperextend at C1 and C2, flex at C6 and C7, what we're looking out for. That's why we're checking the flexion and extension of the neck. If there is any restriction of movements can be present because of rheumatoid arthritis, osteoarthritis, any ankylosing spondylitis, or any previous surgeries. If there is this restriction of movements, then again, you need to suspect a difficult intubation because you might not be able to have the airway in an ideal position to intubate the patient. So that was known as Lemon assessment. You have done the Lemon assessment, airway assessment, and you are planning to go ahead with the intubation. Intubation, you cannot just do it off in an awake patient. You need to sedate the patient or you need to give anesthetic drugs. So you need to give a drug which causes hypnosis of the patient, which gives a good analgesic effect and causes muscle relaxant. Hypnosis is basically reduce the consciousness, make the patient unconscious. A conscious patient cannot relax enough for you to intubate, so make the patient unconscious. So you want an hypnotic drug. These drugs are known as induction drugs. Muscle relaxants. You want the surrounding muscles, all the muscles in your neck to relax. Okay, that's why you're using a drug which can cause a muscle relaxant. And you are using a drug which can give a good analgesic effect. A good painkiller should be present there because it is a painful procedure. You are stuffing in a tube inside your throat. So it is a painful procedure what you're doing it. So it should have an analgesic effect. So first thing we are looking at the induction drugs. Induction drugs are hypnotic drugs what we are looking out for. There are various drugs you can use it, but internally if we go the three preferred drugs which have been very commonly used nowadays is either ethiomerate, propofol or ketamine. Ketamine is taking lot of burdens, or you can call it as it is kind of preferred drug in emergency department nowadays to use ketamine, followed by the propofol. Ethiomerate depends on the circumstances. Each drug has its advantage and the disadvantage when you're using the drug. First, we'll be seeing the ethiomerate. The advantage of ethiomerate is it reduces the intraocular pressure, it reduces the intracranial pressure, intraocular pressure, and has no effect on the blood pressure. But the problem with this patient is this side effect, what you need to look out for, this side effect. What is that? It kind of suppresses adenocortical adenocortical suppression it causes. So basically it causes decreased cortisol secretion. Decreased cortisol secretion will result in decreased blood pressure in a patient who is septic. So in sepsis, it is not preferred because it has a decreased cortisol secretion. That's why In septic patients, if you want to intubate the patient, accumulate is not preferred. Propofol. Propofol is a very good drug because it is an anticonvulsant property. It reduces the intraarticular pressure and it also has an antiemetic property. The problem is it depresses the respiratory system. It causes depression of the CVS system. So what I'm talking about, there might be incomplete apnea. That is fine if complete apnea because you're intubating and connecting to a mechanical ventilator. The problem lies is it has a depressive effect on the CVS system. It causes a low blood pressure. That is not a desired thing because most of these patients who are critically ill will be hypertensive or will be in the shock. Ketamine. Ketamine is excellent drug because it causes an bronchodilation. So in situations like asthma or COPD, so any lung disorders, it becomes an excellent drug. And it is the only induction drug which has an analgesic effect. The problem with this is it has an increased secretions and it increases the blood pressure. And has something known as emergency phenomena. I will be discussing and talking more about the ketamine and its contraindication because it is heavily tested in the exam because it is very commonly used in the emergency department. In coming up slides, we'll go in more depth about the ketamine. But you need to be aware of where are these drugs acting on. If you go back to the previous questions, they have only asked about ketamine, never asked about propofol, midazolam, or etomidate, because all these three drugs act on GABA A receptors as an agonist with slight difference in how they are acting on. So basically, they're agonist and GABA A receptors. NMDA receptors, only the ketamine acts on, and it is an antagonist at an NMDA receptor. This is one that's why I've highlighted and multiple times tested in the exam because the mechanism of action is quite different compared to other induction drugs. Now we have an hypnosis by using an induction drug. Now we are using an muscle relaxant. Okay, muscles needs to relax. The two categories of muscle relaxants, basically, one is known as non-depolarizing, another one is a depolarizing. The depolarizing one is succinylcholine. The non-depolarizing one, what you need to remember is rocuronium and vecuronium. Okay, the preferred one, usually we use a lot of rocuronium. Just the tachycardia is the one of the side effects. It's otherwise it's a very safe drug what you can use it. Okay, it acts for a long time, 30 to 45 minutes it acts. Vecuronium, it acts still on the longer side. It acts around 60 to 120 minutes, around 2 hours. It acts for very long acting drugs of this non-depolarizing drugs what you are having. Vecuronium is not preferred if the patient is obese or has an liver or renal dysfunction. It is kind of not preferred. We do not advise them to give it because it kind of gets metabolized and excreted, metabolized in the liver and excreted through the kidneys. It might remain in the body for a very long time and have adverse effect. That's why vecuronium is not preferred anyone who is obese or has a liver or renal problems. The most favorite one in the emergency department, extensively used one is succinylcholine. Succinylcholine is also known as suxamethonium. They are one and the same. Do not get confused. The onset is very rapid. Within a minute's time, it gets onset. The duration of action is very short. It is good. We need to have a short duration of action because if you're not able to intubate, you can wake back this patient up because you are giving an muscle relaxant. So all the muscles goes paralysis. He cannot breathe once you are given this drug. But he can start breathing once the effect comes off. That is, after 10 minutes, he can start breathing on his own. So if you're not able to intubate, if you just back mask the patient for next 10 minutes, you can wake this patient. That's the advantage of using an succinylcholine. That's why it is commonly used in succinylcholine and commonly tested in exam also. In exam, they want you to be aware of the contraindication of succinylcholine. What are the possible complications of succinylcholine? Succinylcholine is contraindicated whenever you are suspecting an hyperkalemia. For example, there is a burn patient, a trauma patient, you're suspecting rhabdomyolysis, a bedridden patient, or a patient with an renal failure. You suspect they might be having underlying hyperkalemia, so do not give this drug because it tends to increase by around 0.5 millimoles per liter. It increases if you use an succinylcholine drug. Anyone who is a known case of pseudocholinesterase deficiency, or abnormal pseudocholinesterase activity is there, we do not tend to use it because it causes suxamethonium apnea. What is suxamethonium apnea? The duration of action increases. Apnea means no respiratory efforts. So it is a skeletal muscle relaxant. So there are there is no respiratory efforts at all lasts for a very longer time. So duration here, say I said that it is a short time, around 5 to 9 minutes. I said the duration. Here, what you can happen is it can go to hours together. That is the difficulty in succinylcholine apnea. It is commonly seen where pseudocholinesterase deficiency is there or abnormal levels of pseudocholinesterase is present. Anyone who is known and allergic to this drug, do not give it, can cause anaphylaxis. Bradycardia, if the patient is having bradycardia, especially bradycardia, you need to be worried in children. Whenever you're using in children's, if borderline heart rate is also present around 70, we still tend to avoid using succinylcholine because it can cause bradycardia, a greatest risk in children's. Malignant hypothermia, it is an autosomal disorder. And basically, the antidote is dentrolin, what we are treating with. We'll be discussing more about this in environmental chapter along with other hypothermias. These two are important: congenital myotonic disorders, familial or personal. It is only that patient remember, or family-related congenital myotonic diseases if present, or it is a skeletal muscle myopathies like Dickinson's muscular dystrophy. If you're suspecting any of these muscular disorders, do not give it because it causes severe rhabdomyolysis, resulting in hyperkalemia and resulting in arrhythmia. That's why this have been extensively tested in the exam. You need to be aware of. Next one is analgesia. Opiates is preferred one. In opiates is the fentanyl, which is preferred one. Nowadays, they are using all fentanyl. All fentanyl is almost 10 times more potent than fentanyl. Fentanyl itself is almost 10 times more potent than morphine itself. Okay, they are powerful analgesic effect they have having. Both fentanyl, all fentanyl is the latest one, and they are preferring to use all fentanyl nowadays. So we know what the analgesia, what we are giving. We know what is the skeletal muscle relaxants, what we are giving. One thing you might have noticed that I didn't talk about the dosage. I didn't talk about the dosing here also. So remembering the dose is not required. It is not expected of you to remember the dose. Okay, so don't spend time on remembering the dose. If you want for your practical purpose, you can remember the dose. Otherwise, from exam point of view, it is not required. Once you have arranged the necessary drugs, make sure you have the necessary equipments. Okay, first for laryngoscope, you need to have an laryngoscope itself of different blade size. Usually for an adult, 3 and 4 size is a must to have it. ET tube of different sizes, you will be having it. At least one size below and one size above what you'll be having it. For females, it is recommended 7.5. For males, it is recommended 8. So have an 8 and 9 size. Have an 8 and have an 7 size also available depending on male and female what you're having. Airway adjuncts like oropharyngeal airway, nasopharyngeal airway, Megal's forceps if some foreign body you are suspecting, supraglottic airway devices, Bucci might be required. A stylet, which is not seen here, might be required. A syringe to inflate the ET tube will be required. A tie will be required. A tape will be required. So make sure all the equipments what are required is available, including difficult airway equipments. Also, it's advisable because it's an emergency situation. You are intubating, emergency rapid sequential intubation, what you're doing. So what we do in steps of rapid sequential intubation. The first thing what you'll be doing is pre-oxygenation. What is pre-oxygenation? Pre-oxygenation is you're giving the patient high flow oxygen. That means high concentrated oxygen you are giving. Usually in a normal room air, when you are breathing, the total air contains only 21% of the oxygen. What you are trying to do here is give high percentage of the oxygen. If the patient is breathing on himself, the non-breathing mask with a high flow oxygen, you're giving the patient so that they breathe. What will happen if they breathe it? It replaces the nitrogen with complete oxygen in the lungs. If complete oxygen is present in the lungs, that means you have that extra time to intubate when the patient stops breathing. That's the advantage here. You usually pre-oxygenate for around 3 minutes so that the entire nitrogen which is present in your lungs is replaced by the oxygen. So it is completely oxygen which is present in your lungs. That gives extra leverage for you. So the patient doesn't breathe, also has the enough oxygen to survive for at least for 1 minute time. Drugs, we are already aware of. Then you're giving a cricoid pressure. What is cricoid pressure? You're applying the pressure over the cricoid cartilage. What is the advantage of doing this? When you apply the pressure over the cricoid cartilage, it causes pressure over the esophagus, which is right behind the trachea. So it collapses the esophagus. If the patient is not in the fasting state, there might be a reflex because of the relaxation of the lower esophageal sphincter when you give skeletal muscle relaxants. That might cause reflux of the food particles, might eventually result in aspiration. To prevent that reflex, to prevent the food to enter into the lungs cavity, basically you are doing this so that the food will be here in the windpipe. It will not be coming in the mouth and getting aspirated. That's why you are applying the cricoid cartilage. Cricoid cartilage is an hard structure, so it will not cause collapse of the trachea. It will only cause pressure over the esophagus, causing collapse of the esophagus or compression of the esophagus. Then do a laryngoscope and intubate the patient. Once you are intubated, confirm the position of the tube. The best, sorry, the best way to confirm the position of the tube is by visualizing the vocal cords. Okay, you're visualizing the tube passing through the vocal cords is the best method. The second best method is by using an ETCO2 monitoring. Another thing is, before you intubate, between this cricoid pressure and doing a laryngoscope, you want the patient to be in an ideal position. The ideal position is flexion at this lower neck, that is around C6 and C7, extension at C1 and C2. Atlanto-occipital extension, it is called, sorry, Atlanto-occipital extension, what it is called as. This is known as sniffing position. Why sniffing position is important? Because oral axis, laryngeal axis, and pharyngeal axis all come in alignment, and it opens the airway. It helps you to easily visualize the epiglottis and the vocal cords. For that particular reason, it is preferred for the patient to be in sniffing position. To have this patient in sniffing position, you elevate the occipital region by around 10 centimeters by placing a bed sheet or a small pillow. Usually a ring will be available in the operation theaters. If the same thing is available in your ED, you can use it to intubate the patient easily. So pre-oxygenate, drugs, cricoid pressure, sniffing position, laryngoscope, intubate, and confirm the placement of the tube. It is not always that you will be able to intubate while you do a laryngoscope. There might be difficulty for intubations. Whenever you have a difficulty for intubation, that's when you follow this algorithm. What you will do first, plan A. Plan A is check the head and neck position. Is it in proper sniffing position or not? Okay, if you have failed to intubate, pre-oxygenate again so that you have enough time to intubate. Look that if the muscles are adequately relaxed. If not, give more dose to adequately relax. Direct or video. Video laryngoscope is an excellent equipment. Okay, use and video laryngoscope what is recommended. Maximum attempts are 3+1. What do I mean by 3+1? 3 attempts are for anyone. For example, it might be emergency physician who is doing. The extra one attempt what you are having is only for the expert. Who is an expert? Usually a consultant anesthetic is an expert because he intubates day in and day out and he's been doing that for years together. That's why I will call him as an expert. So consultant anesthetic doctor will be doing the additional one attempt. Try doing an external laryngeal manipulation. What is external laryngeal manipulation? That is known as burp technique. Burp itself is an mnemonic where you will be holding the thyroid cartilage and you will be pushing it backwards. Okay. Then you'll be pushing it upwards. Then you will be moving it towards the right side. So it is in burp position. Backwards, upwards, right position. It is known as burp as a mnemonic, what you can remember. If required, as I showed you, you can use a bougie and railroad the endotracheal tube. Remove the cricoid pressure and try to see if that is possible to intubate. Okay, so always when you're re-intubating, always pre-oxygenate the patient before you try and again attempt. Before another attempt, you should always pre-oxygenate the patient. You have done 3+1 time and you have failed to intubate, then you will enter into plan B. Plan B, it is recommended you use second generation devices. What are the second generation devices? These are the second generation supraglottic airway devices. The preferred one is the middle one, which is known as iGel because it is kind of manufactured in the UK. That's why it is preferred in the UK. It's an excellent second generation supraglottic airway device that you will be using it. You are able to place it and you are able to ventilate the patient, then think what can be done, what is required for this patient. Is it best to wake up the patient and wait for the experts to be there and decide what next to be done? Or can I intubate through the supraglottic airway device? There are special supraglottic airway devices available. Through that, you can pass the ET tube. Can you do that one? Is it possible in this patient? You'll ask yourself. Can I proceed at treating this patient without tracheal intubation? Can I just use an NIV? It's not a must for this patient. Then just use an NIV. No, I definitely require an definitive airway. Then you might have to go ahead with a tracheostomy. Who is the expert in tracheostomy? ENT surgeons. Involve the ENT surgeons. What you are doing by placing a supraglottic airway device is buying the time. You're buying the time, you stop and think what next to be done. Plan B is failed. You're not able to place the supraglottic airway device, or you place the supraglottic airway device, but you are not able to ventilate. What you will do? You will enter into the plan C. In plan C, what you are basically doing is face mask ventilation, back mask ventilation. You are doing it like an ambu bag, what you're using it, and you're trying to ventilate the patient. Or you might be using a water circuit and try to ventilate the patient. There is a difference between both, but you're trying to ventilate the patient. Are you able to ventilate the patient? Are you able to see the chest rise or not? If not, use two persons technique and make sure the head position and the neck position is adequate. If you are able to do a mass ventilation, always wake the patient up. Okay, do not give any other drugs. Usually you are using succinyl choline. It lasts for 10 minutes. So just ventilate for the 10 minutes. He'll wake up, have all the experts available, decide whether you want to do a tracheostomy or you can just proceed it without the intubation, then proceed with the intubation in that manner. No, you have failed it. At that point of time, what you'll be doing? Front of neck access is required. The preferred one is the scalpel cricothyroidotomy. How is an scalpel cricothyroidotomy done? What you do in scalpel cricothyroidotomy is first you palpate the thyroid cartilage. Okay, then you palpate, sorry, first you palpate the thyroid cartilage, then you palpate the cricoid cartilage, stabilize it. In between the thyroid cartilage and the cricoid, sorry, in between the thyroid cartilage and the cricoid cartilage is the cricothyroid membrane. This is the cricothyroid membrane. You're making a stab incision horizontal as shown here in the picture. Once you've made a stab incision, rotate your scalpel by 90 degrees. Once you rotate by a scalpel by 90 degrees, the incision what you have made opens up. Then use the bougie and place it in the trachea. Once you place the bougie inside the trachea, you will railroad the endotracheal tube. So let me repeat it. You are making a stab incision over the cricothyroid membrane. Then you're rotating the scalpel by 90 degrees so that the incision what you have made opens up. Then you are passing the bougie. Over the bougie, you are railroading the endotracheal tube. What if your anatomy is not good? For example, if it's a pediatric age group or an obese patient, then just make an horizontal long vertical incision around 8 to 10 centimeters over the neck. Start doing a blunt dissection. Once you reach the cricothyroid membrane, again, do and stab horizontal incision, then rotate it by 90 degrees, railroad the pass the bougie, then railroad the endotracheal tube. That is basically what you will be doing here. That is known as scalpel cricothyroidotomy. There is something known as needle cricothyroidotomy. It is kind of, though I have written preferred method in pediatrics, still it is not preferred in the pediatrics also. Okay, though I have written here, it is not preferred in pediatrics also. This is the preferred method. For some reason, if you're not able to do an cricothyroidotomy, then needle cricothyroidotomy can be done. What you will be doing is, again here, palpate the thyroid cartilage, palpate the cricoid cartilage. In between the thyroid and cricoid cartilage, a large bow cannula will be placed. Okay, with it attached to a needle, attached to a syringe. Continuous negative sectioning you will be doing. Once you aspirate the air, you know that you are inside the trachea. Once you are inside the trachea, disconnect it and connect the oxygen what you are having. The problem here is you can just oxygenate the patient. You cannot ventilate the patient. What do I mean by ventilate? Ventilate means you cannot give the air in the pressure. That means pressurized air cannot be given through this method. You can just give high flow oxygen or concentrated oxygen can be given here. There is a technique how you give it 1 second on and 4 seconds off. What do I mean by this? The patient has to breathe out also. So you will be connecting the oxygen for 1 second. Then you'll be disconnecting for another 4 seconds so that the patient expires out or breathes out. Basically, for expiration, for 4 seconds, you'll be disconnecting. Then again, connect 1 second for inspiration. That's how you'll be connecting and disconnecting. How much of concentration or what flow of oxygen you will be giving? You'll be giving around 15 liters per minute. What you'll be giving, that is a high flow oxygen in adult. Children's, depending on the age. For example, if it's a 4 years old, you will be giving 4 liters per minute. If it is 10 years old, then you'll be giving 10 liters per minute. 2 years old, then you're giving 2 liters per minute. So exactly age in years, so many liters what you'll be giving. One more thing, what I want you to remember here is you're trying to intubate. How long can you keep trying to do a laryngoscopy? You're trying to manipulate. Can you keep it indefinitely? No, you cannot do it indefinitely. You need to abort. When do you abort it? A crude way, what usually the anesthetics, if you ask them, they'll be saying that take a deep breath and hold it and try to intubate till you're able to hold your breath, you can attempt it. That's a crude method to do it. The best method is to look at an SpO2 levels. If the SpO2 levels reaches 92%, abort it. Because you have pre-oxygenated the patient, SpO2 levels will be in 100%. If they've fallen to 92%, that means the curve has come here. See here, from 100 to 92%, it has taken a longer duration. From 92%, it starts falling very rapidly. The patient will get deoxygenated very rapidly. The chances of patient having hypoxic injuries, especially hypoxic brain injuries, are on the higher side. So abort the attempt of intubation and start pre-oxygenating the patient once the SpO2 values are 92 or less than 92. Stop it immediately and pre-oxygenate, then reattempt. That is the importance of this curve, what I have put up here. We will assume that now you are able to successfully place an endotracheal tube. Now you need to confirm that whether the endotracheal tube is in fact inside the trachea itself. How do you confirm it? One method, as I already told you, is you will directly visualize it passing through the vocal cord. Okay. This is depends on the person who is seeing. He might say, I have visualized. He might not have visualized at all. So it is more subjective thing. The second best way they call it is to look out for end-tidal carbon dioxide value. This point, what you need to look out for. So you will be connecting an capnography. On the monitor, when you are seeing, you get a waveform. This is known as normal capnography waveform, what you're seeing here. Let us break down this waveform. Okay. Whenever you are breathing out, so this is a sensor basically. You consider this as an ET tube. When you're breathing out, the sensor is present here. It will pick up the carbon dioxide levels, what are there. Okay, so when you're breathing out, when your expiration starts, the carbon dioxide, what you're expiring out, will increase drastically. Why? First, you're breathing out the air which is present in the trachea, which doesn't participate in exchange of the gases at all. Once you go deeper, the exchange of gases will increase. Maximum will be in the alveoli. So there is a sudden increase in carbon dioxide values when you are expiring. Reaches a plateau when you reach the alveoli because that is the maximum concentration what you are having. But slowly still it will be increasing because the deeper the alveoli is located, the more the carbon dioxide will be present. At the end of expiration, that is the end of tidal volume. Okay, that's why it is known as end tidal carbon dioxide volume. This point is EtCO2. At the end will be the maximum carbon dioxide value. It is the end of expiration. At the end of expiration, you'll start breathing. Once you start breathing, the carbon dioxide values will fall down drastically and it will come back to the baseline. This is the normal waveform capnography. Tested previously, you need to be aware of. The normal value is 4 to 4.5 kilopascals. Sometimes they might give in millimeters of mercury, it is 35 to 45, but remember in kilopascals, 4 to 4.5 is the normal range. Few abnormalities of the waveform capnography, what you need to be aware of. You can see each breath you have this one waveform, what you are having here. He's breathing fast. And the carbon dioxide values have come down. So what is this? This is nothing but hyperventilation. So he is breathing fast. When he is breathing fast, there is carbon dioxide washout. Because of the carbon dioxide washout, EtCO2 values have come down. And the waves are very frequently seen because he is breathing fast. Exactly opposite of this is known as hypoventilation. What happens in hypoventilation? The patient is breathing slow. The patient is breathing slow, thus the respiratory rate has come down. If the respiratory rate has come down, there will be carbon dioxide retention. So that's why the EtCO2 values have gone up. This, imagine it is an cardiac arrest. Okay, in cardiac arrest, you're doing CPR, it's going on. Suddenly you notice in the monitor that there is drastic increase in EtCO2 values. It has shot up suddenly. This usually is suggestive of return of spontaneous circulation. You need to check for the pulse if it is present. If the pulse is present and you have this one, then you have achieved the ROSC, that is return of spontaneous circulation. If it appears like a shark fin, this is the shark fin what I'm talking about. If it appears like a shark fin, then you're thinking of an obstructive airway disease. This is known as obstructive airway disease. Here you can see gradually it is deteriorating, it is going down. This is nothing but respiratory failure. So respiratory failure happens. It doesn't like suddenly it becomes like this. No, this is not the waveform what you're seeing in respiratory failure. This is the waveform what you're seeing in respiratory failure. It will not, it's not like an on-off switch what happens. Slowly it deteriorates. First, you will be using your accessory muscles. Accessory muscles one by one will start failing. That's when you'll start failing and respiratory failure completely. That's why the graph is in this way. Going downward slope, what you'll be seeing in respiratory failure. Another one, what you can see here is the patient is breathing normally, and suddenly you have an kind of a flat line. What are the causes for kind of a flat line? It might be completely kinked ET tube, or the ventilator is failed, or the device, the carbon dioxide analyzer is defective, or there is complete disconnection of the analyzer, the device itself. So the two scenarios are present here. If it is a completely kinked ET tube which is present, which is unlikely to be happening all of a sudden. Complete obstruction. If this is the ET tube what you're having, you should be completely kinked like this to have a flat line, which is a rare thing. So you can kind of ignore the first cause. So there might be a ventilator defect. Yeah, ventilator defect is the one thing. Another one is something wrong with the device. That is the carbon dioxide analyzer what you are having. The waveform capnography over time. Something wrong with the waveform capnography. There is a difference between this. If something is wrong with the equipment to pick up the carbon dioxide, the patient will be stable. His vital parameters, especially the SpO2 levels, will be stable. If there is a ventilator failure, the mechanical ventilator has failed to work. At that point of time, what happens? There is no air which is entering into the patient. That means SpO2 values, the patient becomes unstable. The SpO2 values starts falling down. In these situations, what you do is you immediately disconnect from the ventilator and start doing an bag mask ventilation. Okay. Basically, you connect the ET tube to an ambu bag and start ventilating the patient here. Then see what is wrong with the ventilator and correct the ventilator. Here, what you will be doing, there's something wrong with the device. So device, you will be replacing it, or if you can correct it, what's wrong with the device. If there is a disconnection of the sensor or the device itself is not working, use a new device or reconnect back the sensor which has been disconnected. Here, what you can see is the baseline, what is increasing and increasing and increasing. That means there is retention of the air, what you are seeing. When do we see the retention of the air? In obstructive airway disease, especially the asthma. What is this? This is nothing but dynamic hyperinflation. Okay, dynamic hyperinflation, what we have learned in our resuscitation chapter. If you put an EtCO2, this is how you will be looking at an waveform capnography. This is known as dynamic hyperinflation, where you might have to disconnect the ET tube which is connected and apply the pressure externally and relieve the air what has been accumulated in the lungs. Okay, this is dynamic hyperinflation, or also known as gas trapping. We have discussed this in detail about the gas trapping or dynamic hyperinflation in the resuscitation chapter. Here, just what we are looking at is how does the waveform looks like. Types of ventilators, it will not be tested because it is not expected of you at the MRCM level. It is more for an FRCM level, what you need to be aware of. So this is for your self-study, what I have given here. I have not deleted or I have not deleted anything from your blueprint here. So you can go through your blueprint. If you're interested in ventilators, the modes of ventilators, what you're having, the ventilator settings, what you can look at. Here, if the patient is morbidly obese, there are few changes what you need to be aware of. The sniffing position, what you usually get is not preferred. The ramped up position, this is known as ramped up position, is preferred one. Along with reverse Tenderberg position, the cot itself is elevated here. The entire cot is elevated. This is known as reverse Tenderberg position. The sternal notch and the face should be in the same horizontal plane, and the face should be parallel to that of the ceiling, what you try to achieve it. So ramped up position, reverse Tenderberg position, sternum should be in the same plane of the face, and the face parallel to the roof, what you are trying to achieve it. In that way, this is the best position to intubate in an obese patient. So there are changes in an obese patient. What you need to do, you need to be aware of. Before I enter into the procedural sedation, anyone has any doubts? All right. We are not seeing any doubts, so we'll enter into the procedural sedation. As the name suggests, you are sedating the patient so that you can perform a procedure. What kind of procedures? For example, ankle dislocation, we talked about, I mentioned about procedural sedation there. So you want to relocate back the position or reduce the dislocation, what is there, ankle dislocation, you can do it. Okay, in those manners, any procedures which is quite painful, you want to perform it, you are using a procedural sedation. So procedural sedation is also known as conscious sedation or also known as moderate sedation. So this is the one what we are learning today. What you can see here is airway reflexes, respiratory efforts, and cardiovascular effects kind of remains intact till you're giving a general anesthesia where all the reflexes will be lost. The main differentiating factor is the verbal response, what you need to be aware of. In minimal sedation, verbal response will be normal. If you ask John, what did you had in your breakfast? I had some pancakes and bacon hills. So it is completely fine verbal response what you are having. What about in the moderate sedation? In moderate sedation, there is a purposeful response to an external stimulus. That is, John, what did you had in your breakfast? I had. What did you have in your breakfast? I had pancake. So he will be giving in that manner. It will not be like a normal conversation. It is like a drowsy patient when you're talking about, or you're just woken up the, for example, a normal person, you just woke him up and ask him, what did you have in your breakfast? How you get a response? In that manner, he will be responding. That is known as purposeful response. In deep sedation, repeated stimulus, painful stimulus is required. Repeated painful stimulus you give, then he gives a purposeful response, then it is a deep sedation. There is no response, he's unconscious, then he has gone into a general anesthesia. Our aim is to get the patient at this level, that is the moderate sedation, also known as postural sedation, also known as conscious sedation. So remember this part, important, tested multiple times in exam, because this is the one which will help you to differentiate between minimal, moderate, and deep sedation. So, like any sedations, it should be treated like how you intubate the patient in the similar manner. So you need to collect the history. What history? What do you need to collect? Medical history is the ample history what you'll be collecting. Ample is a mnemonic. Ask him, do you have any allergies? Any medications he is on? Okay. Any past medical history you'll be asking about. Then last meal, when did he had, and what were the events leading to it? With this history, what you'll be doing is you will be doing an ASA classification. ASA stands for American Society of Anesthesia. Though it is an American Society of Anesthesia classification, it is followed in the UK also, kind of followed worldwide, this classification. What is the importance of this classification? Class, that is grade 1 and grade 2, or class 1 and class 2. If the patient falls under American Society of Anesthesiology class 1 or class 2, you can perform it by an emergency physician can perform the conscious sedation in the emergency department. If it is class 3, 4, 5, at that point of time, you need to involve the anesthetic. You as an emergency physician shouldn't be doing the conscious sedation for this patient. You need to involve the anesthetic. You're not qualified to do a patient who is a class 3 or class 4. So the questions will appear on class 2 and class 3 differentiating factors. The easier way to remember here is any disease the patient might be having, it is well controlled or it is mild. So remember, it is a well controlled or it is a mild version what you're having. For example, the patient might be having asthma, but I rarely use inhalers and I don't even remember when was the last time I used it. So it's a mild lung disease. I use inhaler every day, twice daily. That means that this is not a mild disorder, at least moderate or severe asthma what he is having. I'm non-diabetic and hypertensive, but it is well controlled. I'm taking medications. My sugar levels are within normal range. My HbA1c is in the normal range. My blood pressure is in the normal range. So that is normal. A social drinker. Many people drink socially. A smoker, a pregnant woman, or obesity, which BMI is less than 40, but more than 30. Okay, that obesity comes here. So remember the obesity, a smoker comes here, a social drinker is important here. Alcohol dependent or alcohol abuse persons comes in grade 3. Poorly controlled diabetes, hypertension, or any lung disorders comes here. Obesity where BMI is more than or equal to 40 also comes here. That's the differentiating factor what you need to remember. Along with it, anyone who is having a dialysis or had an MI recently or had a CVA or the same thing, it gets worse here. So anyone has worse disease than this, for example, had an ischemic heart disease, had a stroke, had a recently placed a stent, or recently he was discharged for sepsis or was in shock. Those are obviously very severe. It will be easier to pick it up. So just remember that anything which is well controlled or mild, a smoker comes as class 2, a social alcohol drinker, and the obesity where the BMI is less than 40 can be done by an emergency physician, conscious sedation. Otherwise, you're referring to the anesthetic. That is the takeaway from this slide, what I'm having. Let's go back to this slide, what you're having. The last one is you're doing an airway assessment. What airway assessment? We already learned this. This is the same airway assessment what we do for endotracheal intubation and what we do for conscious sedation also. This is an lemon assessment what you'll be doing. During lemon assessment, if you find out this can be a difficult intubation, then you will be referring this patient to the anesthesia drugs. Anesthetic, you will be referring to this patient, you will be referring the anesthetic specialist so that they can do an conscious sedation. Why you are not doing it? Because the anesthetic drugs what you are using can cause respiratory depression where you might have to intubate the patient. That's why we are involving the anesthetic. Let them take over the conscious sedation because they are the experts in those parameters. One more thing, they might ask you, why are you doing an airway assessment? Because the drug what you're using it, for example, midazolam, for example, propofol, can cause respiratory depression and there might be respiratory failure. At that point of time, you might have to secure the airway. So it is good to in hand know that whether it is a difficult airway or you can go ahead and do it yourself. That's why you're doing an lemon assessment. Usually a checklist will be there. You will be going through the checklist and going each one of this following through the checklist what you're having. Next, staffing. At least one doctor should be there for the procedure. At least one doctor should be there for the conscious sedation. At least one trained nurse should be there to assist you. So minimum requirements is 2 doctors plus 1 nurse. Usually the skilled staff member is always a nurse most of the time. So one skilled healthcare professional, that is a nurse, and 2 doctors is the minimum staffing or the minimum requirement personnel required to do an conscious sedation. Where do you perform in conscious sedation? Conscious sedation is done in a setting where you have full resuscitation equipments, including ETCO2 monitoring, at least cardiac monitoring should be there. You should be able to monitor the SpO2 values, that is the oxygen saturation values, non-invasive blood pressure monitoring should be there. Um, all airway equipments, including the difficult airway equipment, should be present in the vicinity. Most of the time, it is present in the resuscitation room. So most of the time, you end up doing it in the resuscitation room. The equipments you need to make sure before you give the conscious sedation is oxygen. Is the oxygen port is there, oxygen mask, working condition, is a suction available, is there a tilting trolley and the patient is on the tilting trolley. Both the basic airway equipments and the advanced airway equipments are available. Reversible agents, depending on the drugs what you're using. For example, you're using morphine, use naloxone. For example, you're using diazepam, midazolam, benzodiazepine drugs, then flumazenil will be required. Make sure you have a good IV access. What are the monitorings you need to do it? SpO2 value, that is the saturation, SpO2 value, that is the saturations what you need to look out for. Continuous cardiac monitoring, so 3-lead ECG monitoring should be done on the cardiac monitor. Respiratory rate and the depth needs to be checked. GCS should be calculated every 5 minutes. Non-invasive blood pressure monitoring. You did not get an arterial line. It's a non-invasive, that is a BP cuff, what you'll be tying, and you will be checking for the blood pressure every 3 to 5 minutes. What about waveform capnography? Waveform capnography is not mandatory. Okay. If it is available, it is good. It is not an mandatory to have an waveform capnography. If it is available, it is good. But whenever you're using a deep sedation or dissociative sedation, you're doing it, then you need to use an waveform capnography. Dissociative anesthesia usually happens when you're planning to use an ketamine. Deep sedation is deeper. That is not conscious sedation. It is deeper level to the conscious sedation what you are having here, where the purposeful response is only for a painful stimulus. Drug used in the procedural sedation should ideally have this all 4 characteristics. That is, it should be an sedation, make the patient a little bit drowsy and anxiolytic, and it should be amnesia, shouldn't remember the procedure what is happening, that is amnesia, and should have the painkiller effect, analgesic effect should be having. So what are the preferred drugs, or what are the drugs what we usually use it? Midazolam. Midazolam is an anxiolytic, sedative, amnesic, but it doesn't have any analgesic effect. So you need to use an painkiller along with it, like an opioid usually you use it. Dosing, you need not remember it. Onset, you need to remember it within a minute's time, usually onset, but the peak effect takes around 12 minutes and it acts for around 30 minutes, which is most of the time it is not desired. For example, ankle dislocation. If the procedure lasts for only 1.5 minutes, why do you want the patient to have 30 minutes? And the peak effect takes around 12 minutes. It's a longer time. So most of the time, what happens? The onset effect starts in 1 minute and you feel the effect is not adequate, then you tend to give incremental doses. You give more and more and more doses. Suddenly, around 12 minutes, the patient will have an respiratory depression and can go hypotension. So midazolam, for that matter, any benzodiazepines have a depressive effect on CVS, has a depressive effect on respiratory system. So it can cause respiratory failure. It can cause low blood pressure. What do you need to remember? Propofol is a good drug, but the problem is it doesn't have an analgesic effect. It doesn't have an anxiolytic effect. So other drugs needs to be complemented. Why I call it as a good drug? Rapid onset. And the duration is less than 10 minutes. For example, you are given propofol and the patient has gone into a depression or and gone into an apnea. You just ventilate the patient for 10 minutes, he'll come back. Sorry, ventilate the patient for 10 minutes, he'll get back. Okay, then you need not intubate this patient. Here it lasts for a very long time, 30 minutes. So you need to ventilate for 30 minutes, which might not be practically possible. That's the advantage of using an propofol. The side effects, obviously, on respiratory depression, and it has a venodilatory effect. That is nothing, but it can cause low blood pressure. The preferred one nowadays used in and out is the ketamine. Ketamine, we already know it is an antagonist for an NMDA receptor. It has all the four properties what we talked about. Has an amnesia, anxiolytic effect, analgesic effect. It has all the good characteristics what we are looking out for in a drug to perform and procedural sedation. Rapid onset, duration is quite acceptable. The problem here is there is something known as emergency phenomena. What is emergency phenomena? Emergency phenomena happens because ketamine is an dissociative anesthetic. Because it is an dissociative anesthetic, during the recovery time, the patient will feel that they have dissociated from their body. People will describe it as I felt like I'm standing beside my own body and looking myself. So they kind of dissociate from their own body, which is quite threatening. This is known as hallucinations at the recovery time. They are dissociated. They get panicky at that point of time because they are seeing themselves lying down on the cot, which is a very bad scene, or it is a very horrifying experience for the patient. This emergency phenomena can be eliminated by giving an benzodiazepine drugs like an midazolam. A low dose midazolam combined with an ketamine, this effect will go off. The literature have not mentioned it. Literature in the sense, if you see the Tintinelli or Oxford Handbook of Emergency Medicine or Rosen's, have not yet incorporated it. But off-label in the emergency department, they have started using it. So in the exam, do not comment on midazolam addition to the ketamine. I'm expecting in next couple of years, it will be on all the books and it will be tested in the exam. This is for your practical purpose. You need to remember is there is an emergency phenomena which can happen. And it increases the sensitivity of the larynx. So laryngospasm can happen and it increases the secretions. So the side effects or the contraindications of the ketamine you need to be aware of. It increases the pressure. So pulmonary hypertension, it cannot be used because it causes increase in pressure. It causes increase in intracranial hypertension. CSF extractions, it is contraindicated in those because it can worsen the condition. In infants, it is not suggested. Anyone who is having a tracheal surgery stenosis, anyone who is having upper or lower respiratory tract infections, or any procedures in the mouth or pharynx for that matter, it is not recommended in this all four because of laryngospasm can happen because you are manipulating near the larynx. Acute upper respiratory tract infection. It's a simple infection what you are having. You do not use an ketamine because there is an already inflammation of the pharynx. Once you give this drug, it might trigger the laryngospasm and might go into the airway compromise. For that reason, it is not recommended. Altered levels due to acute illness or the injuries. Anyone who is drug intoxicated, or it might be because of psychological or cognitive problems or previous psychological illnesses, you cannot use it. This is because of the altered consciousness due to acute illnesses. Any significant cardiac diseases like an angina, malignant hypertension, or heart failure. Anything which causes increase in intraocular pressure, like an acute angle closure glaucoma, uncontrolled epilepsy, anyone who is a known case of hyperthyroidism or taking any medications of thyroid, porphyria, or prior adverse effects for the ketamine. That means he is known to have allergic reactions for the ketamine. You cannot use it, obviously. This is taken from the RCM itself. This holds good. This is many people come back. It is not given there in this book, this is given in the rcm guidelines. These are in those they have recommended about the contraindications. So this holds good for your exam what you are giving. You have given conscious sedation, you have done the procedure successfully, you're planning to discharge. What is the discharge criteria? Can I just discharge him off? No, you cannot just discharge him off. You need to keep him in the same place where you have done the procedure till his GCS comes back to the normal and his vital signs are come back to the baseline. Okay, for that patient, the normal blood pressure might be 150/90. So it has to come back to the baseline for that particular patient. He should be completely pain-free. He should be able to walk, or his baseline mobility should be regained. If he's able, usually he walks with a stick, so he should be able to walk with a stick. Or usually he's able to walk without any support, then he's able to walk without the support. He should be able to take liquid, so give him some water. He should be able to take few sips, and he's tolerating the liquids very well, not vomiting. A responsible adult should be accompanying the person for next 24 hours, and next 24 hours he shouldn't drive. He shouldn't operate any heavy machineries. He shouldn't be involved any legal things, including signing any legal documents. You shouldn't be doing for next 24 hours. You need to arrange a follow. Make sure if follow-up is required, you have arranged it. Make sure adequate analgesias you have given it. All this information should be explained verbally and also needs to be given in the written form. Post-procedure monitoring, multiple times tested, multiple times people get confused, should be in the same place where the procedure has been taken, or should have same requirements. That means should have all the resuscitative equipments, including the basic airway and advanced airway, including the cardiac monitor, SpO2 monitoring, non-invasive blood pressure monitorings. All those parameters should be present when you're observing. You cannot just take him out of the resuscitation room once you have done it. You need to keep there till he meets all these criteria. That is about the conscious sedation. Heavily tested in the exam. Expect at least one question to come through the conscious sedation. Next one is the Penthrox. Penthrox has gained lot of, it is kind of very famous now, and lot of people are using Penthrox. Penthrox is a brand name what you are having. The drug name is methoxyflurane. It's a general anesthetic drug, methoxyflurane. It comes in this manner, and it's very much similar to an electrical cigarette what you are having. In the same manner, it is designed also what you are having it. Usually, it will have 3 ml in it. What you do here is you open the tap here, pour it over here, ask the patient to close his lips, breathe in and breathe out through this opening what you're having, the mouthpiece what you're having. He'll be breathing in and breathing out. And it gives a good analgesic effect. Actually, it gives an excellent analgesic effect. So usually what is it is recommended 3 ml, you use it as an one dose. Okay, can you repeat it? Yeah, you can repeat it. Maximum what you can give is up to 6 ml in a single setting. Okay, it is not advised to give in consecutive days. Maximum what you can give is 15 ml per week. What are the contraindications of methoxyflurane? Because it is extensively used. It is extensively tested in the exam also. Similar to how ketamine contraindications are extensively tested, here also methoxyflurane is extensively tested in the exam. So be aware of it. Hypersensitivity. Any allergic reaction known for methoxyflurane, do not use it. He is a known case of malignant hypothermia. Do not use it because it is an autosomal dominant disorder for any general anesthesia. This is also a general anesthesia, can cause malignant hypertension. Malignant hyperthermia. Patient is there is a family history of adverse reaction for any inhaled anesthetic drug. You shouldn't use it. There are history of signs of liver damage from the previous methoxyflurane usage or previous any inhaled anesthetic what you use it. Significant renal impairment is not CKD grade 1 or grade 2 what we are talking about. Grade 3 or 4 what we are talking about. So anything more than or equal to grade 3 CKD, then it is significant renal impairment. Otherwise, it is not an contraindication. Someone mild kidney injury, you can still use it. Altered level of altered level of consciousness due to an head injury, drugs, or alcohol intake, cardiovascular instability, that is very significant tachycardia, that is arrhythmia the patient is in, or the patient or the patient is having hypertension. For example, you want to give an conscious sedation, instead of that you are planning to use an methoxyfluorine to give and shock for and tachyarrhythmia, then it is not allowed because he's unstable, cardiovascularly unstable. Any severe respiratory depression is present, he is hypoxic, do not give methoxyfluorine. Hypoxic, hypotension, altered level of consciousness, significant renal impairment, signs of liver damage is present, any family history of allergies, or he's an allergic to it, or he is a known case of malignant hypothermia, do not give this drug. It is a contraindication. Entanox. Entanox is very commonly used. It is in cylinder. In that, it has a gas. This gas is a mixture of nitrous oxide and oxygen. 50-50 ratio, it will be mixed with nitrous oxide and oxygen is mixed. Rapid onset of action. Once you stop breathing it, the action will disappear. Very short duration of action. Once you stop breathing it, within 1 minute, you'll be completely fine to normal. There are contraindications. Any air-filled spaces, air-filled spaces. Remember that air-filled spaces. If any air-filled spaces are there, pathological air-filled spaces like a pneumothorax, bowel obstruction, middle ear or sinus infections or head injuries, and where you are seeing a pneumocephalus. So any pathological air-filled spaces are present, it is contraindicated because nitrous oxide is more soluble than oxygen and nitrogen. So it tends to diffuse in this and gets accumulated there. That's why it is contraindicated. Another side effects which is very commonly tested in the primary exam is megaloblastic anemia due to vitamin B12 deficiency. So Entanox, that is nitrous oxide, can cause vitamin B12 deficiency, but it is seen someone uses it chronically. That means someone is abusing it. So abusing it, then you see and vitamin B12 deficiency leading to megaloblastic anemia. You giving him in the emergency department for 15-20 minutes will not cause vitamin B12 deficiency leading to megaloblastic anemia. So this is someone who is abusing the drug, keeping the cylinder at home and using it for hours together, for days together. Then you might have an vitamin B12 deficiency leading to megaloblastic anemia. I'll just see if anyone has questions. I'll take it before I go into enter into the pain management. Again, no questions, so we will proceed ahead. Assessment. How to assess a patient who is having a pain. Or for that matter, any patient who comes to the emergency department, a pain assessment to be done. A pain assessment to be done within 15 minutes of arrival to the emergency department. For any patient, he doesn't have a pain also, if he has a severe pain also, within 15 minutes, you need to do an initial assessment. You will ask and the patient to grade it. If it's a mild pain between 1 to 3, if he grades it 4 to 6, it is a moderate. Anything 7 or more than 7 is a severe. So what you will be telling to the patient, you tell him 10 being the worst pain of your life, 1 being is almost negligible pain. How do you like to grade your pain, what you are having it? Then he'll give a score. Accordingly, you will be grading it. Once you have done an initial assessment, okay, depending on mild pain, you'll be giving drugs, moderate pain, accordingly, you'll be giving the drugs. Once you have given the drugs, you need to reassess the patient. If there is no pain, then ask him after 1 hour, do you have any pain now? If it's a mild pain, again, after 1 hour, check him, how is your pain? I have given some analgesia, has it improved? Moderate, check him within 30 minutes. Severe, within 15 minutes, ask him, is the pain better now? You had a severe pain. Are you feeling better now? Those questions needs to be asked for. What are the drugs what we'll be giving? Before giving drugs, ask yourself, can I just splint it? Okay. Or can I just give and block? For example, it's a femur neck fracture. Can I give an fascia iliaca block for the patient? Those are better than giving an parental drug. Anyways, parental drug can be rapidly given. For example, fascia iliaca block takes time to do it and takes time for this action because you're using an bupivacaine, a longer acting one, what we'll be learning today. Basically, you're using an bupivacaine, which is a longer acting one, which may not be sufficing your needs. For that reason, you eventually end up giving parental drugs. What are the drugs? If it's a mild, just give paracetamol. 1 gram paracetamol, you can give it, or give an NSAID. If it's a moderate pain, like paracetamol or NSAID, you will be giving. Along with it, if you are only given paracetamol, add an NSAID. If you are already given an NSAID, then add up an codeine. Okay, codeine is the preferred one. You're adding up here. So if you're not given NSAID, you're giving an NSAID. If you're NSAID, you're already chosen here, then you're adding an codeine. What about in the severe pain? Severe pain, opiates is the preferred one. IV opiates, morphine is the preferred one. You end up giving morphine for this patient. What about rectal NSAID I have mentioned? In certain situations, especially in an ureteric calculi, remember this multiple times tested in the exam. Uh, ureteric calculi, the best painkiller is giving rectal NSAID. Okay, rectal NSAIDs is the preferred one what you'll be giving. Do not forget this. Its preferred route is PR. That's why I call it rectal NSAIDs. You can give it in intravenous, also intramuscular, also you can give it. But the preferred route is again it is rectal. And only opioid shouldn't be given. You should always supplement with other oral analgesic, also like a paracetamol, codeine, and NSAIDs, so that you have an synergistic effect. What about in elderly patients? In elderly patients, paracetamol is the preferred one. They advise do not use an NSAIDs. If you're using opiates because the patient is having severe pain, use lower dose of opiates. In pregnancy, it is better to avoid it as much as possible. Do not give any drugs at all. It is recommended do not prescribe at all. Unless the patient is requesting a lot, then you can give the paracetamol. It is the best one. Okay, do not give any NSAIDs. Ibuprofen, you need to avoid it in third semester, can be given in first and second trimester. Morphine and codeine can be given in all the trimester unless the patient is having very severe pain. Do not give morphine and codeine. It has an depressive effect and it can cause uterine growth retardations. Those kind of complications can happen because of morphine and codeine. It is not recommended to give it. If at all, if you're forced to give it, then you will be choosing one of these opioid drugs. Preferred one is always avoided. Second preferred one is paracetamol. Third preferred one is directly go ahead with the opioids. Non-systemic drug treatment plans, relaxation technique. A kid is panicked. Divert his mind by showing some cartoons or play with him some games that might divert his mind and have relaxing effect, and the pain might come down drastically. Local or regional anesthetic. For example, someone who is having a burns over the hand, give and wrist block, excellent analgesic effect. Immobilization, especially for the fractures. If you just immobilize it, splint the fracture. Splinting the fracture itself will help the pain to come down drastically. So splinting should be done wherever possible. If there is a dislocation, for example, shoulder dislocation, ankle dislocation, just reduce the dislocation. The pain will disappear like a magic. So try to reduce it as soon as possible. So the pain management is excellent. What about in the pediatric age group? Till now, what you have discussed is about the adults. In pediatric age group, assessing for the pain might be a little bit difficult. What we do is we show the faces. Ask the kid which kind of pain, how severe is the pain. Can you just point out the stickers? You can just show him the stickers on a piece of paper and ask him to pick it up. He might pick this one or he might pick this one, depending on how severe is the pain. You can look at his behavior and see whether he's normal and completely moving around, no decrease in movements or no restriction of the movements are present. There is slight restriction of, then it is no pain you can consider. Slight restriction of movements, he's rubbing the affected area, but he's talking and he's able to play, then mild pain. There is quite a bit of restriction of the movements and the patient is crying, but it is consolable and he's trying to protect his area, not allowing anyone to touch it, then moderate pain. Severe pain is the one where the patient might be very quiet, one extreme. The other extreme is he is crying continuously and you're not able to console him at all. Then you will think of very severe pain. These are the few examples here, like an large burn or a fracture is a severe pain examples. Appendicitis or a small burn, then moderate kind of pain. Some laceration or some ankle or knee sprains are present, mild. A bump on the head is a classical example for no pain. Usually pain disappears within few minutes. How do you manage? The management remains very much similar to that of the adults. Once you are given the drugs, you are reassessing after 60 minutes, 30 minutes, 15 minutes, same as adults, no changes there. What about the mild one? You're giving paracetamol and ibuprofen, plus or minus. It's similar to that of what we learned for the adult also. The changes are seen in the moderate pain. Few changes, what you need. If you have not given diclofenac or an ibuprofen for the male pain, basically NSAIDs you are not given, give an NSAID here. Okay. Add up and codeine if the kid is more than 12 years old. Less than 12 years old, then oral morphine, which is preferred. All right. Remember this. Codeine is contraindicated anyone who is less than 12 years old because the metabolism and the duration of action is unpredictable. It can act for longer duration, it can stay in the bloodstream for a longer duration and cause toxicity. That's why the other opioid drug which is preferred is oral morphine. It comes as a syrup, you can give it. Severe pain, the preferred one is intranasal dimorph. This is 10 times more potent than morphine. It is preferred in the pediatric age group mainly because it is given intranasally. That's why it is preferred. And you need not gain an IV access. Gaining an IV access itself is a stressful procedure for the kid. He might start crying for the IV access itself. So giving an intranasal dimorph is the preferred one, more preferred than giving IV morphine. You can see in the NICE guidelines, they have mentioned that consider Entonox as an interim measure. This is mainly for the paramedics. Okay, it is not for emergency doctors. Imagine a patient, a kid, 7 years old, in severe pain. Do you think he'll be cooperative enough uh, to take an deep breaths using the Entonox, what you are having? No, he'll not be cooperative too. He'll be crying continuously. Okay, giving an intranasal dimorph will be much quicker and much effective. This is mainly for paramedics, and they say consider. They're not recommending it. Consider, they're saying it. Always supplement with oral analgesia, as we have discussed, similar to adults and similar to pediatrics. There are no changes. Okay, this part is important. This part is important because it is different from the adults. It is being tested previously. Local anesthetic, another important topic here. Local anesthetic, you might have heard of lidocaine, very commonly used. Otherwise, you can mix an lidocaine with an adrenaline, so the duration of action increases. You can use a long-acting local anesthetic like an bupivacaine. You can use an prilocaine also. This is the only licensed drug to use it intravenously. Onset of time for lidocaine or lidocaine mixed with adrenaline is within few minutes. But the duration of action lasts for a longer duration when you mix it with adrenaline. And here it acts approximately for 30 to 60 minutes. Dosing. Dosing in only plain lidocaine, if you're using, is 3 mg per kg. When you mix it with adrenaline, you can go up to 7 mg per kg. Though I'm mentioning in child, it is 3 mg per kg, but you can use this same formula to calculate for the adult also if you're aware of the weight. If the weight is not given, then you can directly assume it is 200 mg per kg. If the weight is given, then calculate according to 3 mg per kg. Same thing holds good for all the drugs what I have mentioned here. Bupivacaine is much slower than lidocaine. It takes few minutes, 5 to 10 minutes. It takes minimum to start acting. It acts for longer duration, minimum of 3 hours. It acts sometimes it can act for 8 hours. So it is an excellent drug to give someone where you want an analgesic effect. That's why in fascia iliaca block you tend to use an bupivacaine. Levobupivacaine is the preferred one. What is the dosing? 2 mg per kg. In adults, 150 mg, or you can use the same formula itself can be used to calculate if you're aware of the weight of the person. Prilocaine, within few minutes it acts, 30 to 60 minutes the duration of the action, 6 mg per kg in childs. Same thing you can use it to calculate for the adults. This dosing calculation differs from literature to literature. For example, Rosen's, if you compare to Tintinelli, it's different. Tintinelli, if you compare to Oxford Handbook Book of Emergency Medicine, it is different. We recommend you to follow this one because it is taken from Oxford Handbook of Emergency Medicine. It is an UK author who has written it, and it is a UK book which is there. So this holds good for your exam, what you are giving it. Things I need to mention a little bit more on: why does the duration of action increases if you mix the adrenaline? Because adrenaline is a powerful vasoconstrictor. As is a powerful vasoconstrictor, the the local anesthetic what you're infiltrating remains in the same region for a longer duration. For that reason, the duration of action increases. For the same reason, as it doesn't enter into the systemic circulation because it is a powerful vasoconstrictor, you can use a larger dosing. Almost more than double what you can use it. 3 mg per kg is the only plain lidocaine. Here you're using 7 mg per kg. Up to that level, what you can use it. Previously, before the MCQ questions appeared, that is around 3 to 4 years back, they used to give this kind of questions and ask you to calculate. Few things what you need to be aware of. As a general doctor itself, you need to be aware of these things. Whenever a drug is mentioned as 1%, what do they mean by it? They mean is 1 gram is present in 100 ml. This is the meaning of this one. Okay. So 1000 milligrams is present in 100 ml. So 1 milligram is present in 10 sorry, 10 mg, 10 milligram is present in 1 ml. What do you need to remember? Another thing is, I might have told in anesthesia, registration chapter 1 is to 10,000 ratio. What is 1 is to 1,000 ratio? What does this mean? 1 is to 1,000 means 1 gram is present in 1,000 ml. 1 gram is nothing but 1,000 mg is present in 1,000 ml. So 1 mg is present in 1 ml. That's what you need to remember. It is important. Previously, they used to give the calculations like this question, what we are having, which can appear in your exam. Doesn't mean till now it has not appeared, it will not appear. So you need to be aware of. We have a 65 years old weighing around 70 kgs present to the ED with a lacerated wound. You plan to do and switching another local anesthetic using and lidocaine 1% plain. Plain means adrenaline is not mixed. What is the maximum dose which can be administered? Is 70 kgs. Okay, 70 kgs. So what we can give, it is a plain into 3. So 210 mg what I can give to this patient. So how many mLs can I give? 10 mg is present in 1 ml. So I can give 21 ml here because 10 mg is present in 1 ml. Sorry, 10 mg is present in 1 ml. So 210 mg will be present in how much? 210 divided by 10, it is 21 ml has 210 mg. So 21 ml is the maximum dose what I can give to this person. That's how you will be doing the calculations. Complications of local anesthetic. Easier way to remember is it causes CNS depression. So it has an convulsion eventually going into coma. That is confusion, muscle twitching, convulsion, coma. Easy to remember is CNS depressant. It is also an cardiovascular depressant. So it will cause bradycardia, hypotension, cardiac blocks, and go into the arrhythmias. It is also an respiratory depression. So it will cause an respiratory depression and respiratory arrest. So it is that way, the late complications are easy. These are all late complications, what I told you for. Easy to remember: CNS depression, severe depression, respiratory depression. But what they will be testing you on is this complications, the early signs. The earlier you pick it up, the better it is. Okay, so earlier you pick it up, you can intervene earlier and you can prevent all this. You can prevent the patient going into the coma. You can prevent the patient going into hypertension. You can prevent the patient going into respiratory arrest. So picking it up earlier is the most important. So this signs what you need to remember. Remember that in the head, lightheadedness, ringing sensation in the ear, circumoral numbness in the face, and metallic taste inside the mouth. So whatever you are having, it's in the head itself. Lightheadedness, tinnitus, circumoral numbness, and metallic taste, all in the face itself what you are having it. In that way, remember this will be tested. What is the antidote for this? Antidote is the lipid emulsion, what you need to remember. You need not remember all the dosing what you have been given. It is only for your reference purpose. No one can remember. It is quite complicated dosing what I have mentioned here. Okay. It's the lipid emulsion. What you need to remember, the antidote. Whenever you use this antidote, we always admit the patient. Why do we admit the patient? Because it is notorious to cause pancreatitis. Previously tested again in the exam. Previously tested here. So the antidote of local anesthetic, for example, the patient develops an tinnitus, then immediately you give an lipid emulsion and you admit the patient, because over the days, the patient might develop an pancreatitis. So they need to closely observe for pancreatitis, signs and symptoms of pancreatitis. Before I go into non-invasive ventilation, anyone has any questions? All right, we'll enter into the non-invasive ventilation. Non-invasive ventilation, sometimes it can be interchanged and grossly called as continuous positive airway pressure, CPAP. Okay, continuous positive airway pressure, CPAP, it can be called as, it can be interchanged. But strictly speaking, non-invasive ventilator can be a CPAP or can be an BiPAP. What is CPAP? There is a continuous pressure. So the end positive airway pressure will be present here. It is also known as PEEP. In BiPAP, there are fluctuation in the pressure of the air what you are inserting into the into the lungs basically. So end positive airway pressure, and you have an inspiratory positive airway pressure. This is also known as expiratory positive airway pressure. Okay, more correct term is expiratory positive pressure and inspiratory positive airway pressure. What is the advantage of using an NIV? The advantage of using an NIV is the functional residual capacity will increase. Basically, your lung capacity will increase. How? Some alveoli might be collapsed. As you're pushing the air under the pressure, this alveoli gets opened up and gets recruited. So guys, that's why recruitment of the alveoli will be there. Once the alveoli is opened up, once it reaches the adequate pressure, this pressure will be transmitted to an adjacent alveoli which is collapsed. That alveoli also opens up. This is known as splinting of the air. And there is a reduction in the work of breathing. Your respiratory muscles can relax a little bit because you're pushing the air under the pressure. So you need not suck the air. To suck the air, your respiratory muscles needs to act. So work of breathing will reduce drastically. The pressure which is across the left ventricle, that is known as intramural pressure. Left intramural pressure will reduce. That will help to increase the ejection fraction. That is basically increase the cardiac output. And as you are delivering the air, you can deliver the high concentrated oxygen up to 100% FiO2. Also, you can deliver fraction. FiO2 stands for fraction of inspired oxygen. Before you start an NIV, you need to rule out a pneumothorax. Either you get an bedside echo done and rule it, bedside ultrasound scan done and rule it, or get an chest X-ray done. It is an aerosol generating procedure. That's why this during the COVID time, they started saying that whenever you are planning to use an NIV, always you first wear personal protective equipments. Like an N95 mask is a must when you start an NIV because it can spread to you. The patient might be having an COVID. So this new thing came up during the COVID time. If the patient is having dentures, place the dentures inside because you need to have a good seal. Repeat the ABG, that is arterial blood gas, after an hour's time. What are the indications to start an NIV? What is the contraindications? What is the NIV setup? What you need to be aware of? This is taken from BTS guidelines, British Thoracic Society guidelines. I have the simplified version here. That's what you need to remember for your exam or for the practical purpose to practice in the emergency department. What is the indications? Indications, especially in the COPD where we extensively use an NIV, what are the indications? If the pH is less than 7.35, but the related contraindication is pH being less than 7.15. So pH between 7.35 to 7.15 is an indication. If it goes below 7.15 is an relative contraindication. Remember that. PaCO2 values, that is carbon dioxide values, are 6.5, more than 6.5. Respiratory rate is more than 23. These parameters usually we look after giving the medical treatment for an hour's time and they have not improved. And these are the parameters which are present. Any one of these parameters, for example, respiratory rate is 24. That's an indication. PaCO2 value is 7. That is an indication. pH is 7.3. That is an indication to go ahead with an BiPAP. That is an NIV to go ahead with. What are the absolute contraindication to use an NIV? Any facial deformities is present. Any facial burn is present. Fixed upper airway obstructions are the absolute contraindications. One more absolute contraindications, what I want you guys to add up and remember here is anyone who is having a recurrent vomiting in spite of giving anti-emetic drugs. You're given anti-emetic drugs but still continues to have vomiting, then the chances of aspiration is very high because it is a tight, fixed, big mask what you're using. He'll vomit into the mask and he'll aspirate off. For that reason, it is contraindicated. It's an absolute contraindication. Related contraindication is pH less than 7.15, GCS less than 6. Some confusion, agitation, or cognition impairment is also a relative contraindication. NIV settings. What is the minimum NIV settings you need to have it? Minimum NIV settings what you're having is expiratory positive airway pressure of 3, inspiratory positive airway pressure of 15. So 15 is to 3 usually we call it. Okay. In neuromuscular disorders, if it is, then you can or you should decrease it to 10 is to 3 is the minimum what they call it. What about maximum? Maximum you as an emergency physician is 30 is to 2. This is an inspiratory positive airway pressure. This is an expiratory positive airway pressure. Do not exceed this limit without having an expert review. That means do not exceed it before you consult with a chest physician. Inspiratory expiratory ratio. It is preferred to be in 1:2 ratio, inspiratory respiratory ratio, and you can increase it to 1:3 also. What do I mean by inspiratory expiratory ratio? For example, you inspire for 1 second and you expire for 2 seconds. That is the ratio, inspiratory to expiratory ratio, the duration you're giving. For example, this is 1 second you're inspiring and 3 seconds you are expiring. This can be reduced to 1:1. 1 second you're inspiring, 1 second you are expiring in other disorders like in chest wall diseases or neuromuscular diseases or obstructive airway diseases, like an obstructive airway diseases, in those conditions, you can do it. Sorry. In those conditions, you can go for an 1:1 ratio. Monitoring and red flags, what you need to be aware of. Okay, if the pH is less than 7.25, try to optimize the NRV settings what you are having. If there is a new onset of confusion, you need to closely monitor. If there is a new onset of confusion and the GCS reduces, and if it is less than 8, you might have to intubate the patient at that point of time or change the NIV settings at that point of time. So you need to be closely monitoring for this. These are the red flags what you need to be monitoring. What about NIV in asthma and pneumonia? It's not indicated. It's not recommended that you use NIV in an asthmatic patient or a pneumonia patient. It is not indicated. Remember this, in asthma patient, we directly go for intubation. In the next class in the respiratory, I'll be talking, do not use an NIV, directly go for intubation if indications are present. Settings are important, tested, previous diet also they have tested for. We know inspiratory positive pressure. Inspiratory positive pressure means the pressure with which the air is entering into the trachea and into the lungs during inspiration. That's why inspiratory positive airway pressure. The air which is entering into your lungs during expiration in the positive airway pressure. This is important. Why is it important? During expiration, you're breathing out, but you're still pushing the air in a slightly less pressure. Why you're trying to push the air in a slightly less pressure? Because you want the alveoli to be open. If you do not have pressure in your lungs, it will collapse. If the alveoli collapses, to reinflate it, you need very high pressure or this alveoli is gone waste. It is similar to a balloon. If you inflated a balloon a little bit, blowing air in that inflated balloon is much easier. Then a balloon which is completely collapsed, you need much more energy to blow it if the balloon is completely collapsed. In the same way, the alveoli also. That's why expiratory positive airway pressure is important, which is also known as PEEP. RR stands for respiratory rate. FiO2 stands for fraction of inspired oxygen. Okay, in normal room air, it is only 21%. You can go as high as 100%. What you are inspiring is completely oxygen. Inspiratory to expiratory ratio, we kind of fix it to 1:2. Depending on here, what I've told you, we fix it. We do not usually change around. COPD 1:2, we keep it. Other disorders, usually we keep it 1:1. We do not mingle it. So what are the changes, what you need to do with, or what are the settings, what you need to do with if there is an high PaCO2 values? If high PaCO2 values are there, you need to breathe out a lot. So more air should come out of your lungs, expire out so that you can wash out the carbon dioxide. For that reason, the difference between inspiratory positive airway pressure and expiratory airway pressure should be on the higher side. The difference I am asking about. That's why what we do is this one, we keep it at the same reading. Only we will increase the inspiratory positive airway pressure. This one is the same. We are not changing it. Respiratory. The more faster you breathe, the better it is because you are washing out the carbon dioxide, hyperventilation. But if the respiratory rate goes beyond 20, it is not recommended. What happens if the respiratory rate goes beyond 20? You will start just breathing from the trachea itself, not from the lungs. The respiratory rate is so fast, the air exchange is happening only in the trachea itself. What air is there here in the alveoli is still in the alveoli itself. That's why a respiratory rate of 20 is fine. More than 20 is not recommended. Okay, so you'll increase the respiratory rate so that it is approximately around the 20 mark. This has no role for high PaCO2 values, and this one we are not touching it. So what we'll be doing, we'll be increasing the IPAP and increasing the respiratory rate to up to 20 in whenever there is a high PaCO2 values. Next one, what you are seeing here is the low PaO2 values. If the oxygen levels are low, increase the fraction of inspired oxygen. If this is not happening, then increase both IPAP and EPAP equally. By, for example, 2 units of this and 2 units of this, what you will be increasing equally. What if there is a high PaCO2 values and low PaO2 values? What you will be doing is increase the IPAP more than that of the EPAP. And FiO2 increase it. Increasing the FiO2, what will do, will increase and PaO2 values. Increasing the IPAP, what will do, it will decrease the PaCO2 values. This one you are increasing, but not very much. For example, this one you increase by 4 units. This one you just increase by 2 units so that it doesn't affect this parameter. But At the same time, increasing the EPAP will increasing the PaO2 values. To summarize the findings, if there is a high PaO2 values, increase IPAP by 2 units, keep EPAP constant, respiratory rate maintain around 20, FiO2 you're not changing it, keep it constant because it mainly deals with an PaO2 values. If low PaO2 values are there, first thing what you'll be doing is increase the FiO2 to 100%. Still low PaO2 values are persistent, then increase both IPAP and EPAP equally. If there is a high PaCO2 values and low PaO2 values, first what we'll be doing? Increase the IPAP, okay? Remain EPAP, maintain it constant, increase the respiratory rate to 20, increase the fraction of inspired oxygen to max. Once PaO2 is in the normal range, but a PaO2 values is still low, then you start increasing both equally and remain this constant. And this has anyways been on the max itself, continue in the max. The another strategy, what I explained previously, is the same thing here. Increase the IPAP more than that of the EPAP, maintain the respiratory rate around 20, and FiO2 raise it to the max. That should help to reduce the high PaCO2 values and increase the PaO2 values. These findings are important. One more thing what I like to do not start at very maximum settings. NIV maximum settings, you shouldn't start it. You should always start with a minimum settings. Why is it important to always start with a minimum settings? Because there is an air which is coming inside his mouth. There's a large mask, what is having. The patient is conscious. He needs to coordinate with the air, what is coming. So whenever the air is pushed in, he needs to inspire. Whenever the pressure has reduced, he needs to expire. If you start pushing the air with a high pressure, the patient will start panicking. So slowly, incrementally increase it so that he gets used to the NIV. Suddenly, if you increase, it will be a disaster. Let him get used to the NIV. Once he's used to the NIV, then incrementally increase depending on the ABG values what you're having. Any questions? Anyone having? Okay, we'll proceed. We'll proceed ahead about the management of the tracheostomy and laryngectomy. How do you manage a tracheostomy on laryngectomy? First, this is the normal lungs, normal cross-section of the neck what you're having. Tracheostomy is nothing but a hole in front of your neck which is communicating with your trachea. Simple. But it is also communicating with your oral cavity, pharynx, larynx, and it is coming here. Okay. In laryngectomy, it is different. There is a hole here. It is communicating with your trachea. Yes. But this is sealed here. It is not communicating with your oral cavity or pharynx, larynx. It is not communicating. That it is known as laryngectomy. Mainly, it is not communicating with your pharynx. Here, there is a communication with your pharynx. This is the normal anatomy what we are having. That's the difference between tracheostomy and laryngectomy. How? What happens in the emergency department? Chronically ill patients or on tracheostomy, they are discharged home. Suddenly, they come to the emergency department with an blocked tracheostomy. How to manage and block tracheostomy in adult? What we are looking out for. First of all, always call for the help. Then assess if the patient is breathing. If the patient is not breathing, then immediately check for the pulse. If there is no pulse, start CPR. If the patient is breathing, connect him on high flow oxygen, both for the tracheostomy as well as for the mouth. Once you are connected both on the face and the tracheostomy high flow oxygen, start assessing for the tracheostomy patency. First thing what you'll be doing is removing all the attachments which are present along with the inner tube, what you'll be removing it. Next thing what you'll be doing is you'll be passing an suction tube. If you're able to pass the suction tube, it is a partial obstruction, do an ABCD assessment. No, you're not able to pass the suction tube, then deflate the tracheostomy tube. Take a syringe, suction it out, deflate it. Improvement is seen, then it is a partial obstruction, do an ABCD assessment. No improvement is seen, remove the entire tracheostomy tube and see whether there is an improvement. No, you have removed the entire tracheostomy tube. This is the whole what you are seeing. Still no improvement. Then what you'll be doing? See whether the patient is breathing. You remove the tube. If the patient is breathing fine, improvement is seen, ABCD assessment. No, there is no improvement is seen or the patient is not breathing or the pulse is not present, start the CPR immediately. Once you have started the CPR, what you'll be doing? Do and back mask ventilation. How to do and back mask ventilation? To do and back mask ventilation, sorry guys, there's a little bit. To do and back mask ventilation, what you'll be doing is obstruct the stomach. This, place a finger over it, obstruct it, and do and back mask ventilation. If you're not able to do and back mask ventilation, then what you'll be doing is place an pediatric place an pediatric LMA, then oxygenate with an ambu bag. This is a primary oxygenation. You cannot continue doing it. So you will try to do an endotracheal intubation. If endotracheal intubation from the mouth here, endotracheal intubation is failed, then intubate the stoma using a 6 size ET tube, what you'll be doing. So this is the management plan, what you need to be aware of. Let me repeat it. First of all, what you'll be doing is call for the help. Then assess for the breathing. If the breathing is not there and pulse is not there, start the CPR. If the breathing is present, connect the oxygen for both the tracheostomy and the face. Then remove all the attachments which are present, including the inner tube. Then try to pass the suction catheter. If you're not able to pass the suction catheter, deflate the ET tube. Still no improvement is seen after deflating the ET tube. Again, assess whether the patient is breathing and having a pulse. No, start the CPR. Then you need to start the back mask ventilation. To start the back mask ventilation, cover the stoma and do an back mask ventilation. If this is not possible, then you can place an pediatric LMA here and do an back mask ventilation. You can't indefinitely continue this. That's why the second strategy comes in. First, you will be trying an endotracheal intubation. If failed, then you will be putting an ET tube through the stoma 6 size. Now, we'll enter into the pediatric emergency tracheostomy. Best way to learn this one is compare with the adult one so that you know what are the little bit changes easier. If you learn one algorithm, next one, just the changes what are required, you will be learning. Breathing assessment is not there. You're just connecting high flow oxygen to the face and the tracheostomy. Okay, whether to start the CPR, all those things, parameters, what we have learned, this entire box is not there. Just start on high flow oxygen tracheostomy. Rest, remove all the inner tube attachments, can pass the catheter, you will be seeing it for deflate. Some pediatric tracheostomy tubes may not have the cuff. Okay, if there is a cuff, you will be deflating it. Then along with the deflating the cuff, you will be changing the tube also. Okay, change the tube. First attempt, change it with the same size, failed. Then half the size of a smaller tube, failed. Then place an suction catheter, small size suction catheter, try to place it. That's how you will be doing it. All right. No, there is no improvement by doing it. Remove the tracheostomy tube, similar to adults, no changes. Again, assess for the patient breathing here, start CPR. You not immediately start CPR. We usually give 5 rescue breaths, no life, no signs of life. Then you start the CPR. Okay, 5 rescue breaths are given by bag mask ventilation. If that doesn't help, then you can stoma itself. You can ventilate within pediatric LMA. Once you have done this, then you're entering into this. Okay, when you're entering into this oral intubation, you will try it. If the oral intubation fails, then you will intubate through an stoma. Here, you're not using 6 size ET tube, you're using a 3 size ET tube. So very much similar, only with few changes. What you need to remember here, high flow oxygen. Here, along with the deflation, if the cuff is present, along with the deflation, you will be changing the tube. First is same size tube, next is half the size of the tube, then over suction catheter, try to guide it and place the tracheostomy tube. That doesn't work. You are giving 5 inflation breaths, not starting with the CPR, because in pediatric BLS, first what we do is give 5 rescue breaths. Back mask ventilation, tracheostomy tube, everything remains same. Only here the ET tube size from 6, it changes to 3. So very much clear. Comparison wise is the best way to learn. Next one is laryngectomy. How to manage a laryngectomy. Laryngectomy, we are aware that there is no communication here. So if you are sure this is a laryngectomy, you need not place on a mask. How to be sure? Check the old records, take an collateral history. If the patient itself might say it is a laryngectomy. If you're not sure, place the mask. If you're not sure, place the mask over the face and stoma on the both sides. Here, you're not assessing for the tracheostomy patency, you're assessing for the laryngectomy patency. Rest of the parameters remains the same, no changes. Here, again, remains the same, no changes. Bag mask ventilation, you cannot do an in laryngectomy because there is no connection here, no point in doing. Oral intubation is not possible because no connection, no point in doing it. So you directly jump, not in it is not tracheostomy, laryngostomy here it becomes, name will change. Laryngostomy stoma through an pediatric LMA, you'll try to ventilate this patient. After that, you'll try to intubate by using an 6 size ET tube. Okay, this will not be applicable here because of the what laryngectomy basically is. The differentiation factor itself doesn't allow you for an oral intubation or an bag mask ventilation. Management of when tracheostomy bleed also you need to be aware of. A patient might be bleeding from the tracheostomy side. First of all, make the patient sit up. Making the patient sit up holds good for anyone who is bleeding from mouth or from the neck. For example, someone is bleeding from an tonsillar fossa after an tonsillectomy. Make the patient sit up. After a tooth extraction, the patient is bleeding. Make the patient sit up. Why is it important to make the patient sit up? To prevent the aspiration. Okay, if he's in the lying down position, he can aspirate. To prevent the aspiration, you want this patient to be sit up. Suction the airway if there is a lot of blood which is accumulated. Start on the supplementary oxygen. Call for the help as soon as possible. If you feel there is significant loss of blood is systolic blood pressure less than 90, then you are considering there is a significant loss of blood, activate massive transfusion protocol. If it is a local bleeding, that means somewhere here or here it is, I mean, apply direct pressure there. Okay. And you can cauterize by using a silver nitrate. Silver nitrate, just cauterize it, just place it here, it will cauterize and it will stop if it is superficial bleeding what you're having, localized bleeding what you're having. If it's a deep bleeding, what you'll be doing? If it's a deep bleeding, hyperinflate the tracheostomy tube. Do not deflate, hyperinflate the tracheostomy cuff, what you are having. Tracheostomy cuff up to 50 ml of air, what you'll be hyperinflating. Utlis maneuver. What is Utlis maneuver? You're putting your finger here through the tracheostomy and another thumb over the sternum and applying the pressure so that the innominate artery gets compressed and the bleeding stops. This is for the deep bleeding what you're doing. Okay, so the artery between your two digits, you are compressing with your thumb and the index finger and trying to compress and stop the bleeding from that artery. This is known as Utlis maneuver. What you're doing here is then Utlis maneuver. One more thing, from your primary, you must be remembering that the flow of blood or any matter for anything through an tube is directly proportionate to the radius to the power of 4. That means if the radius increases a little bit also, the flow drastically increases. So you need to be aware of yellow size IV cannula is 24 gauge, 13 ml per minute you can give maximum flow. Blue one is 22, 31. Pink 20, 67. Green 18, 103. Gray 16, 236. Orange 14, 260 ml per minute. You can give it within 2 minutes. You can give entire 500 ml of back through an orange cannula. That's the importance of the diameter. Compared to the yellow one, which is 24, compared to this one, 14 got. The difference in the flow, what you need to appreciate. They might test you on this. No, they are not tested. Might test you on this. Similarly, a triple lumen you are having, depending on the size of the triple lumen, what you are having, usually it takes 13 minutes to infuse 1 liter. That is 80 ml per minute it will be having. Triple lumen of 16 gauge you are having, then 120 over 8 minutes. If it is an sheath, what you are having, you are using it to introduce a sheath, 600 ml per minute. So within 2 minutes, you can give 1 liter. Okay. The thing what you need to appreciate is even in central line with a triple lumen, you place it. It requires 13 minutes. You just placing an orange or a gray one, you can actually replaces it in an emergency situation. Just place a gray one. Will be as useful as that of a central line itself. That's the advantage. That's the advantage of just increasing the diameter slightly of an IV cannula. The flow increases drastically. Sometimes they might give you an oxygen cylinder, say that it is an 6D and it has 600 ml. Sorry, 600 liters of oxygen is present. Someone who is on 10 liters, how many minutes it can last for? 60 minutes it can last for. Okay, because 10 ml per minute you will be giving it. So you can use it for 60 minutes, it will last for. So those kind of questions also can appear. That's why I put up this algorithm. If we can remember it. It is not very high yield. It is slightly on the lower side. Till now, it has not appeared. Anyone has any questions, please do ask me now before we enter into the recall questions. Anyone, any questions? Please ask me before we enter into the recall questions. Okay, let's proceed ahead with the recall questions. There are plenty of it. We need to go through it. A 10-year-old kid on tracheostomy was brought to the emergency department in an ambulance. The paramedics handover says that the tracheostomy is blocked. Mom has removed the speaking wall and tried to pass and suction catheter, but failed. On examination, the heart rate is slightly on the higher side, saturation is on the lower side, respiratory rate on high, BP is on the lower side. He's cynosed also. What is the next step? This is basically they are telling tracheostomy is blocked. How do you manage and tracheostomy? Use and small size suction catheters should be the best option. Though mother has suction it, we don't know whether she is an healthcare professional or not, because it requires some amount of training. No one can just come in here and put in tube and suction it out. There is some amount of training should be there to see whether the suction tube is passing or not. So trying this one should be the first thing to do it, because we are not sure whether she has done it rightly or not. That's why we recommend you to choose first option. It's the same algorithm what we have discussed already. A 22 years old male involved in a road traffic accident was brought to the emergency department by paramedics. On arrival to the emergency department, the patient had a low consciousness level. Hence, airway was secured with an endotracheal tube. Post intubation, the patient was shifted to city room for an polycity trauma. While the patient was in city room, the the patient, sorry, he lost complete ETCO2 tracing. The image is shown here. Vital parameters are stable. This is very important. The vital parameters are stable. So what has happened here? Okay, check for the disconnection. Mostly some wires have got disconnected. Check if something has got disconnected. That is the important point what you need to remember here. Check for ETCO2 disconnections. A 8-year-old boy was brought to the emergency department by his mom with an history of fall while playing football. He sustained an injury to the head and has a large lacerated wound. Mom says he is also suffering from upper respiratory tract infection. He denies any headache or vomiting. The patient is hemodynamically stable and the GCS is 15. You decide to suture under sedation and use ketamine. What is the absolute contraindication for ketamine in this patient? Okay. Usually people get confused. They know past medical history of epilepsy is not there. This is not a contraindication. This is not a contraindication. They are confused between head injury and upper respiratory tract infection. The right answer here is the upper respiratory tract infection. Head injury. Are there any signs and symptoms suggestive of an raised ICP in this patient? No. He has not vomited. There is no headache involved. His GCS is fine. All this indicates that there is no rise in intracranial pressure. That's why you need to select upper respiratory tract infection as an absolute contraindication here, because it causes laryngospasm. A 19 years old male present to the ED with an history of fall while he was skating and sustained an injury to the shoulder. X-ray shows an anterior shoulder dislocation. The ED is busy, so you you do not have help for conscious sedation. You decide to do it with an Pentanox. What is the absolute contraindication for Pentanox? They are asking. Diabetes, no. Alcoholic liver disease, there should be signs and symptoms of liver disease which is present, not an alcoholic liver disease. Hypertension, no. Suspected hypothermia, no. If it is a known case of malignant hypothermia, that is a contraindication, not an suspected hypothermia. Hypothermia can be because of a heat stroke also. So the right diagnosis here is GFR less than 30. That means severe renal impairment, significant renal impairment is present. So third option is the right one. Here they're simply asking what is the maximum dose of Penthrox units. They're asking how many units or Penthrox devices you can use it in a day. 6 ml you can use it. Each unit has 3 ml in it. So 2 units you can use it. So the maximum dose is 2. In mLs, if they ask, 6 ml is the maximum dose what you can use. They're asking what is the absolute contraindication for NIV. Absolute contraindication out of the options what are given is the facial burns. Vomiting is relative, confusion relative, agitation is also relative, dementia is also relative. Absolute is facial burn. So remember, facial deformity, facial burns, fixed upper airway obstruction, and recurrent vomiting even after administration of antiemetic are the 4 absolute contraindications for an NIV. Again, similar questions, but the options have changed. Potentially having bulla, is that an absolute contraindication? No. Blood pressure less than 90? No. Confusion and agitation? No, that is not. Decreasing consciousness level? No. Persistent vomiting despite giving antiemetic is an absolute contraindication because he will eventually aspirate. A 78 years old on tracheostomy, a known case of Parkinson's and multiple comorbidities brought to the ED by paramedics with complaints of difficulty in breathing. The ambulance crew handed over the patient saying the tracheostomy has blocked and they have removed the inner tube en route to the emergency department. The patient is still struggling to breathe with the low oxygen saturation. What is the best next step? So inner tube is removed. So next, after removing the inner tube is deflate the tube. So the next option, what is the deflate? Which one has the deflate? Deflate the tracheostomy tube. So the cuff, what is there? That one you're deflating. You're deflating the cuff of the tracheostomy tube. So the option number 5 is the right one. After deflating, you remove the tracheostomy tube. So the second one is not wrong because that is next step. After deflating, removing the tracheostomy tube. If you remove the tracheostomy tube when it is inflated itself, it will cause trauma. It's like pulling out an urethral catheter without deflating it. It will be similar kind of trauma. The same thing what we have discussed. A 61 years old female has slipped and fallen down in the shower and she complains of a pain over the right shoulder. She denies any head injuries or vomiting. X-ray of the right shoulder shows anterior shoulder dislocation of the shoulder. You plan to reduce the shoulder under conscious sedation. The patient is shifted to the resuscitation bay and IV access is gained and administered propofol. So you just administered the propofol. Soon after the administration of propofol, the SpO2 falls to 40%, and you do not appreciate any respiratory effects. What is the immediate action to be taken? What you will do? So what is this? The patient is in respiratory failure or respiratory arrest he is in. Why is in respiratory arrest? Because of the propofol. How long the propofol acts for? Approximately it acts for 10 minutes. So what I'll be doing for the 10 minutes? Just do an bag mask ventilation. One of the bag mask ventilation is water secured with high PIP. So fifth one is the right answer. Someone is asking, they said remove the tube. Eighth one, remove the tracheostomy tube. Remove the tracheostomy tube is after deflation. You need to go suction catheter, they have passed it, then deflate the tube, inner tube is removed. Suction catheter, they have not mentioned it. That's why we will be deflating the tube. This one we have skipped it because they have not mentioned it. So you deflate the tube, then you remove the tracheostomy tube. For that reason, we are removing the tracheostomy tube here. Next one, a 4-year-old child was brought to the ED in the ambulance with ongoing CPR. Resuscitation continued in the ED. After correcting the hypothermia, the ROSC has been acute. Post-ROSC airway was not patent. Hence, anesthetic decided to protect the airway with endotracheal intubation. Suxamethonium is not preferred muscle relaxant. Which of the following condition? In which of the following condition you do not give suxamethonium for this patient? Suxamethonium, hypotension, you can give it. Renal impairment, you can give it. Hypothermia, you can give it. Unless it is an malignant hypothermia, the patient is known case of. He is just an high temperature, you can give it. Hypertension, you can give it. Bradycardia, no, it's a contraindication. Especially in pediatric age group, do not give suxamethonium. It can worsen the bradycardia and cause complete heart block. So fourth one is the right option. A 60-year-old female, a known case of COPD, presents to the ED with a worsening shortness of breath. You make a diagnosis of acute COPD. You initiate medical management and start NIV as the patient is retaining carbon dioxide and respiratory acidosis is worsening. After 1 hour of the ABG shows type 2 respiratory failure. What changes in the NIV you will be doing? I have not taught you type 2 respiratory failure, which we'll be learning in the respiratory chapter. Basically, it means there is retention of PaCO2 values. Okay, high PaCO2 values with low PaO2 values is the type 2 respiratory failure. Okay. What we'll be doing here in type 2 respiratory failure, mainly first thing what we'll be concentrating is the high PaCO2. Sometimes in even PaO2 values might be normal in type 2 respiratory failure. The main parameter what we'll be looking is the high PaCO2 values, then we call it as a type 2 respiratory failure. Increasing FiO2, it just deals with PaO2 values, no use. Therapeutic hypercapnia, you don't know therapeutic hypercapnia in any conditions for that matter. Increasing respiratory rate between 15 to 20. Yes, that is the right answer. Increasing EPAP. No. You have to keep the EPAP constant. Constant what is required. Decreasing the IPAP. No, you need to increase the IPAP. So the right answer here is the third one. This one is wrong because increasing EPAP will increase the PaO2 values, not decrease the PaCO2 values. We need to keep this constant. A 38-year-old female sustained an injury to the hand by a broken glass. She denies any other injuries, and you have given her painkillers on exam. And on examination, there was a gaping wound. Hence, you decide to close the wound by suturing. You infiltrate lidocaine around the wound. After finding the patient develops and metallic taste in the mouth and deteriorates, you administer lipid emulsion immediately and admit the patient to ICU. What is the suspected complication after few days in this patient? Lipid emulsion, they have used it. Whenever they have used a lipid emulsion, pancreatitis is the one we are really worried about. After a few days, it usually develops. It's a side effect or a complication of a lipid emulsion what the patient has been given. You have been teaching about NIV settings to a group of medical students. One of the medical students asked you about the absolute contraindication. So, which one of the following is an absolute contraindication for NIV? pH 7.15, relative, absolute. This is an absolute contraindication. What are the others? Remember, facial deformity, facial burns, recurrent vomiting, even after administration of antiemetics. You should remember the absolute contraindications. This has appeared in September 24 also. A 68 years old was brought to the ED in an ambulance. There is an history of worsening shortness of the breath since morning. Medical management and NIV has not improved the breathing. You decide to intubate the patient using ketamine as an induction drug and succinylcholine as a muscle relaxant. Which one of the following is a contraindication for succinylcholine? Contraindication for succinylcholine, motor neuron disorders. This not. Not tachycardia, bradycardia is a contraindication. Motor neuron diseases, you shouldn't give it. According to the NICE guideline, which is the drug of choice for the analgesia? CT scan has been done suggestive of an ureteric calculi. So giving NSAID per rectally is the best drug. So per rectal diclofenac. For example, here instead of per rectal NSAID, they're not mentioned per rectal, they have mentioned it as an IM or IV, you can choose that one. But if they have given, for example, one is IM diclofenac, one is IV diclofenac, another one is per rectal diclofenac, then choose always per rectal diclofenac. An elderly male patient was brought to the emergency department in an ambulance. On examination, the patient has a low GCS, but maintaining saturation. Due to the low GCS, you plan to intubate the patient. He is a known case of sleep apnea and uncontrolled diabetes. During the evaluation of airway for intubation, it was found that the distance between the mandible and the floor of the mouth was 2 fingers. What makes this patient a difficult intubation? It has to be 3 fingers, not 2 fingers. So this becomes a difficult intubation. They're not asking about ASA grade here. If they ask about ASA grade, then there are multiple things. Uncontrolled diabetes itself is in grade 3, ASA grade 3. They're not asking about grade here. They're asking about difficult intubation. That means they're asking about the Lemon score. If Malampati class 3 or 4 is there, then it becomes a difficult intubation. They have mentioned class 2 here. Low GCS doesn't come in Lemon assessment. Uncontrolled diabetes doesn't come in Lemon assessment. Sleep apnea doesn't come in Lemon assessment. So the right answer is the third one. They are basically asking here, you're planning to discharge and on which analgesia you will be discharging a patient with lower back pain. NICE guidelines suggest that a monotherapy with an NSAID is the preferred drug. There is no logical reason here. They have done some studies and they have said that only plain NSAID as a monotherapy is the preferred. Before they used to tell paracetamol plus NSAID you prescribe. Now latest guideline says, latest guideline says that only prescribe NSAID for the patient. So remember this. This is according to the NICE guideline. They're asking what is the Malampati score here? What is the Malampati score? You can only see the base here. If you see out of this picture, it correlates well with this one, the third one. So this is Malampati 3, class 3. There is nothing known as class 5. It's a tricky question what we are having here. So read carefully. A 34 years old male got injured due to an accident in the factory. He has a severely injured neck, open neck injury as shown in the picture. On examination, the patient has abdominothoracic breathing. Whenever they mention abdominothoracic breathing, always remember that it is an impending respiratory arrest. Okay, any point of time, he'll be having respiratory arrest. Low oxygen saturation, not responding to painful stimulus. What will be the most appropriate next step in management of this patient? You need to secure the airway for this patient for sure shot. Intubate via the neck opening. Can you intubate through the neck opening itself? It is contraindicated to open through the neck opening. We don't know where this passage is going. It might be just under the skin or it might have gone into the esophagus. So it is not a good idea to intubate through the neck opening. Connect oxygen and urgent anesthetic call. It is a good idea if the patient was not having abdominothoracic breathing. That means he's an impending respiratory arrest. Till the anesthetic comes, he will be in arrest. So that's why we are not choosing this one. Cricothyroidotomy. Yes, you can do an cricothyroidotomy. Good idea. Tracheostomy. Yes, good idea. Oral intubation. Yes, good idea. What we need to follow is we need to follow the difficult airway algorithm. In the difficult airway algorithm, what they say? Simple things. First, start with oral intubation. Do 3 attempts plus one for the expert. If you fail at that point of time, then you go for plan B, plan C, plan D. In the plan D, you will be getting a cricothyroidotomy or tracheostomy. That is front of neck access, what you're doing. So oral intubation is the right answer. So break it down in this way and think logically, you will get the answer. What is the maximum IPAP you can increase before an ITB review? Max is 30 IPAP. Max EPAP is 8. They're asking, they have given an waveform capnography here and asking the D. D, what is here? What it suggests. D suggests end tidal carbon dioxide values. At the end of the expiration, the carbon dioxide value which is picked up is known as end tidal carbon dioxide value. That is the D, what you are seeing here. Here is the inspiration, what starts. Here is the plateau phase, which starts with the exchange is happening in the alveoli. Here, from this point, is the maximum point or the end of the expiration and start of the inspiration. That's why it falls down. An elderly male was brought to the ED with complaints of fever and shortness of breath. The patient becomes unconscious in the ED department while you are assessing him. Due to low GCS, the airway was secured with an endotracheal intubation. The patient is planned for an ICU. After a minute of intubation, the oxygen falls. After increasing the FiO2, oxygen falls even after increasing the FiO2 to 100%. After a minute, the patient deteriorates and SpO2 values falls. A chest X-ray was done as shown below. What is the best step in management or treatment of this patient? Let's have a closer look at the chest X-ray. ET tubes are made in such way that there is a strip which is radio opaque. It can be picked up on an X-ray. So what you can see here is the ET tube what you are having. It is going and going into the right main bronchus. So this is the trachea, this is the bronchi. It is going into the right main bronchi. That means it is just ventilating the right lungs. It is not ventilating the left lungs at all. That's why the patient is desaturating. Just withdraw the ET tube by a couple of centimeters. That should be sufficient. So the right answer is the first one. They have given a waveform capnography asking what is the most likely cause for this waveform capnography. What we are seeing here is shark fin appearance. Shark fin appearance. Whenever you see a shark fin appearance, think of an obstructive airway disease. So it is an obstructive airway disease like asthma. Uh, an 8 years old female kid was tripped over the footway and fallen over the right hip. She complains of pain over the right hip and you administer the painkillers and examine the hip joint. The right lower limb is short and externally rotated. You strongly suspect a fracture of the femur and confirm it on an X-ray. The patient continues to have pain, hence you decide to give an fascia iliaca block using an levobupivacaine. What is the dose of levobupivacaine in a fascia iliaca block for the children? It is 2 mg per kg, we know it. The one parameter what I have not explained you is what is fascia iliaca block. We'll be learning about the fascia iliaca block in our procedures. One thing what you need to remember here is it is the area what you need to anesthetize. So you need large amount of fluid. That means large amount of drug should be there. So the lower the concentration you use it, the mLs will increase. So the lowest concentration what we are having, 0.25 what you are selecting, along with 2 mg per kg, 2 mg per kg. That's why we are using the fifth one. Do not worry, we'll be again going through this question during the procedures for a better understanding. A 40 years old obese with a BMI of 39. Female present to the ED, she gives an history of the trauma to the left shoulder, X-ray of the shoulder suggestive of an anterior shoulder dislocation. The diagnosis with, she is recently diagnosed with an hypertension, which is well controlled. She has no other comorbidities. You decide to reduce it in conscious sedation. What is the ASA grading? Hypertension is well controlled. BMI is less than 40, so it is a grade 2. If you change the BMI to 40 itself, then it becomes grade 3. If you change it to well controlled to uncontrolled, then again it becomes grade 3. Okay, you need to be aware of the changes. It is not a grade 1. In grade 1, they do not have hypertension. They are not obese. It's not a grade 1 for that reason. A worried mom brought her a child who is on tracheostomy. Mom thinks the tracheostomy is blocked. You receive the patient immediately in the resuscitation main connect to the cardiac monitor. You fail to pass the suction catheter. The child becomes unresponsive without and central pulse. You immediately start the CPR. The monitor shows pulseless electrical activity. The first dose of adrenaline was been given. What is the most appropriate next step in management? You need to remember one thing when you're managing the tracheostomy. The tracheostomy management doesn't change if the patient is in cardiac arrest or not, because you need to assess the patency of the tube. If the tube is blocked, you're just doing a backbone ventilation without removing a tracheostomy tube is useless. For that reason, you need to always assess the tracheostomy. That needs to be followed if the patient is in failure also. Okay, so assessing is very important. So what are the steps what we are having? First, remove all the attachments what you are having. We'll assume they have removed all the attachments because they are not mentioned anything. Next step is next step is change the inner tube if present. Sometimes inner tube might not be present. Change the inner tube if present. Has they mentioned inner tube present? They just told that they have failed to pass the suction tube. So we'll assume the inner tube might not be present there. They had removed the inner tube. So they have just failed to pass the suction catheter. If they fail to pass the suction catheter, next step will be deflate the tracheostomy tube. Because next step should have been here. Sorry, there is a little bit here. Change the tracheostomy tube, pass the suction catheter. Has they passed the suction catheter? Yes, they have passed the suction catheter. Okay, if they have passed the suction catheter, still not responding, then you need to deflate the tracheostomy tube. This is the first one. Let me repeat it again so that I have missed a little bit. That's why I'm repeating here. First one is remove the speaking wall or anything which is present there. Second step is to change the inner tube. You're not removing, you're changing the inner tube if present. If not present, you're not changing it. Next one is to pass the suction catheter. What they have mentioned here is they have passed the suction catheter and they have failed it. So we need to go to fourth step. Fourth step is deflate the cuff. Have they deflated the cuff? They're not mentioned that they deflated the cuff here. So here the right answer will be the deflated cuff. If they have deflated the cuff, the fifth step is to change the tracheostomy tube. So this is the sequence of order. The right answer here is the fifth one. What is the minimum number trained professional is required for unconscious sedation? They are asking. Minimum is required is 2 doctors and 1 nurse. 1 doctor is to perform the procedure. 1 doctor is to give the conscious sedation. 1 nurse to help you out. What it can be any healthcare trained healthcare professional also. This question has appeared in September 24. They're basically asking you to calculate the ET tube size. It is a 4 years old kid. So what is the formula what we are using? Age divided by 4 plus 4 we are learned in our resuscitation chapter is 4 years old. So 4 divided by 4 plus 4 is 1 plus 4 is 5. So right answer is the fifth one. They are not mentioned it cuffed or uncuffed. That's why I'm using this formula. Usually they stopped mentioning it as cuffed or uncuffed. It is understood. This is the formula what you're supposed to use it. Now we have a 2 years old kid. Again, they have asked you to calculate the ET tube size. So age divided by 4 plus 4 is the formula what we are using there because they are not mentioned cuffed or uncuffed. So this is the formula what we'll be using it. So 2 divided by 4 plus 4, it will be 0.5 plus 4. It is nothing but 4.5. So the right answer is the first one, 4.5. They're asking what is the maximum EPAP you can set. IPAP maximum, already the question had come, it is 30. EPAP maximum, what you can set is 8. So EPAP maximum setting is 8. Fourth one is the right answer. Here they are asking what is the contraindication for Entonox. We are aware that air-filled spaces is the contraindication for Entonox. So out of this option, which is the air-filled space, pneumothorax. So pneumothorax is the right answer. A 8 years old kid has fallen down from the bicycle. He sustained an injury to the right lower limb. His parents have brought him to the emergency department. An X-ray of the right femur shaft shows that there is a fracture. Kid is crying in the department with pain and says the pain is 10 out of 10. What is the drug of choice? Severe pain the patient is Q-dimorph. Okay, dimorph is intranasal dimorph is the choice of drug. 16 years old, known case of bronchial asthma present to the ED with worsening of the breathing difficulties. ABG shows metabolic acidosis. You decide to intubate the patient and ventilate. Drug of choice for induction. Ketamine, because it has an bronchodilator function. Because of this, you are using it in asthma as the drug of choice, ketamine for induction. Where does ketamine act on? Ketamine acts on which receptor? They're asking. The next question is an NMDA receptor which acts on. Remember that NMDA receptor which acts on. Mu receptors are for opioid drugs. Beta receptors are basically beta blockers. You can be like a metoprolol or bisoprolol. So various drugs or beta receptor stimulants might be like salbutamol. Alpha receptor stimulants like prazosin, usually used to relax. Prazosin or trazocin, you can use it. Prazosin, usually used to relax the urethral sphincter. GABA receptors, propofol, antagonist, benzodiazepines like diazepam, midazolam, antagonist. 29 years old male presents to the ED with shoulder dislocation. You reduce the shoulder under conscious sedation in the resuscitation bay. You check the X-ray and confirm the reduction. The patient is still drowsy and being observed in the resuscitation room. The nurse informs you that there is another patient in need of the resuscitation bay. What action is to be taken? Discharge the patient immediately. No, you cannot discharge because the patient's level of consciousness is not back to normal. So wrong. Wait for a relative of the patient to arrive, then discharge. No, the patient, all vital parameters, including the level of consciousness, to come back to the normal. You cannot discharge. You cannot observe anywhere else other than where the procedure or other than where the all the equipments are available. Shift to minor for observation. No, you cannot do or shift to the minors also. You need to observe in a place where all the resuscitation equipments are available. In minors, you will not have a difficult airway trolley, a basic airway support. All those parameters, cardiac monitoring will not be available. Discharge the patient when the pain has subsided and all the vital parameters return to the baseline is most appropriate phrase. So the fourth one is the right answer. A 44 involved in a road traffic accident sustained multiple injuries. Paramedics have gained IV access and started an IV fluid. The patient is received in the resuscitation bay. You are doing an airway assessment. Which one of the following is not an sign of impending respiratory arrest? Which is not an impending respiratory arrest? They are asking which one? It has appeared in September 24. Biphasic stridor. That means airway is narrowed. So he can have impending respiratory arrest at any point of time. Grunting, yes. Drooling of the saliva. Why? He's not able to swallow. That means something seriously wrong. Gurgling. Yes. This pooling of the secretion. That's why you get this gurgling sound what you're having. Expiratory wheeze. Someone who is having asthma also has a respiratory wheeze. Doesn't mean he is in impending respiratory arrest he is having. So the right answer is expiratory wheeze or just a wheeze. It can be inspiratory or expiratory. How to know when the patient is in a state of deep sedation? Deep sedation is purposeful response for painful stimulus is deep sedation. Moderate sedation, also known as conscious sedation, also known as procedural sedation, is the second one, purposeful response for verbal stimulus. Normal response for verbal stimulus is nothing but minimal sedation. State of unconsciousness is general anesthesia. Purposeful response for tactile stimulus, any external stimulus it can be. Okay, this is also nothing but moderate sedation or an procedural sedation level. What is the indication to start NIV in this patient? They are asking and they are given the vital parameters. PaCO2 values more than 6.5, not 6. pH less than 7.35, it is in the normal range, you're not giving it. Respiratory rate more than 23, here it is 29. Yes, this is the right answer. Bicarb is not an indication at all. Heart rate is not an indication at all. This is an indication in a COPD patient. Let's revise once again. pH should be less than 7.35. PaCO2 values should be more than 6.5. Respiratory rate should be more than 23. These are the indications for NIV to start in a COPD patient. This has appeared in September 24. A 21 years old female came to the emergency department with a shoulder injury. X-ray of the shoulder joint confirmed shoulder dislocation. She has no comorbidities. You plan to reduce the shoulder under procedural sedation. IV access was secured and propofol was given for the procedural sedation. You notice ETCO2 tracing in the monitoring as shown below. What is the most likely cause? What has happened? He has taken propofol. Propofol is known to cause respiratory depression. So this, sorry. Yes, respiratory depression propofol is known to cause. So once there is a respiratory depression, there is gradual increase in carbon dioxide. EtCO2 values have increased over the time. This is mainly because of hypoventilation. So the right answer here is hypoventilation. It is a normal EtCO2 tracing. No, it is an abnormal EtCO2 tracing because there was an hypoventilation which is happening. In September 24, when it appeared, there was one more option they had given there where they had mentioned it as a tube block. Can tube block produce this kind of unlikely tube block will produce this kind of parameter. Tube block, it will obstruct the airflow itself. So the EtCO2 values what you are having will fall down because there is no airway movement at all. Expiratory air is not coming. If expiratory air is not coming, your sensors cannot pick up anything. A middle-aged male involved in a fight was brought to the ED in an ambulance. You notice multiple facial injuries on examination. The airway is compromised along with tachycardia, tachypnea, hypertension, and hypoxia. What is the best next step in management of this patient? What you'll be doing for this patient? A middle-aged fight with multiple facial injuries. What you will be doing for this patient? Refer to the ITU, cricothyroidotomy directly, surgical reference, back mass ventilation, difficult airway trolley. Get an difficult airway trolley because you're suspecting a difficult airway because there are facial asymmetry because of the facial injuries which is present. Bring the difficult airway trolley. Young male, a known case of bronchial asthma presents to the ED with severe breathing difficulties and his oxygen levels are very on the lower side in spite of connecting 10 liters of oxygen. Rest of the parameters seems fine. ABG shows type 1, that is PaO2 values on the lower side. You opted to proceed with intubation and ventilation, but have decided against using suxamethonium as a skeletal muscle relaxant. Contraindication for suxamethonium. So simply they're asking contraindication for suxamethonium. Out of this, the fifth one is a contraindication for suxamethonium because it will cause severe life-threatening rhabdomyolysis resulting in hypokalemia, which can be catastrophic. This one again has appeared in September 24. A patient with a laryngectomy was brought to the emergency department, shortness of breath. You shift the patient to the resuscitation and connect to the cardiac monitor. On tachycardia, tachypnea, blood pressure is fine, saturation on the lower side, BM is fine, GCS is slightly on the lower side. What is the initial step? You're suspecting a laryngectomy obstruction. First thing is apply the oxygen. Where you'll apply? To the stoma. Face doesn't make sense because he's already a known case of laryngectomy. There is no connection between the oral cavity and the trachea. So the first step what you are having, high flow oxygen for the laryngectomy stoma. 18 years old has fallen down from a height of 12 feet. He sustained multiple injuries to the face. On assessment, the airway is compromised. Hence, you decide to intubate and ventilate the patient. Your senior anesthetic has failed to intubate even after multiple attempts. And you are unable to back mask the patient due to facial injuries. What is the next best step in airway management? So multiple steps have been done here. So multiple times intubated, not possible. Back mass ventilation, not possible. So we need to jump to plan D. What does plan D says? Front of neck access. Out of this, which is the front of neck access? Cricothyroidotomy. Video laryngoscopy. It should be plan A. They have already attempted multiple times. Fiber optic intubation, plan A. Direct laryngoscopy, plan A. They have already attempted multiple times. Even the anesthetic consultant is present, the senior anesthetic is present who has tried. So front of neck access, what do you need to do? That is cricothyroidotomy. Which one of the following is a contraindication for suxamethonium? It is kind of a repeat question. It is a bradycardia. Especially in the pediatric age group, we are really worried about it is a bradycardia. It has repeated the similar kind of question with different wordings what has come here. A middle-aged man was found agitated and aggressive outside in the supermarket. Paramedics physically restrained him and brought to the emergency department. The patient was sedated and intubated in the ED to get the CT head done. Suxamethonium, propofol, and fentanyl were used for intubation. The patient was planned for extubation, but no respiratory efforts were seen. What is the likely cause? What are the respiratory efforts? Respiratory efforts means respiratory muscles are contracting. They're not contracting. Still, they are paralyzed. You're given suxamethonium. Suxamethonium should act for only few minutes. Approximately, it acts for 10 minutes. Not more than 10 minutes. It doesn't act usually. It is acting for a longer time. Why is it acting for a longer time? You need to suspect and suxamethonium apnea. Suxamethonium apnea is because of deficient cholinesterase or abnormal cholinesterase, pseudocholinesterase. So cholinesterase deficiency. A 55 years old male unknown case of COPD brought to the ED with worsening shortness of breath, APG done type 2 respiratory failure, and NIV started initially with a setting of EPAP and IPAP of this readings. After 1 hour, you got this readings. What is the NIV changes? What do you need to do? There is high PaCO2 values still and high PaO2 values. So increase both IPAP and EPAP. It will only address this one, will not address this one. Increase IPAP. It will address this one, will not address this one. Increase EPAP will address only this one. Increase both IPAP and FiO2. Increasing IPAP will decrease the PaCO2 values. Increasing the FiO2 values will, sorry, will increase the PaO2 values. So the right answer is this one. Decreasing FiO2 values will cause decrease in PaCO2 values. We do not want this because PaO2 values are on the lower side itself. So the fourth one is the right option. A 13 years old male sustained an injury to the face as a truck hit his cycle. On examination, the airway is compromised. You decide to secure the airway. You have administered succinylcholine and propofol. Multiple attempts by you and anesthetic have failed to intubate the patient, and you are unable to backmask ventilate the patient. What is the next most appropriate? Again, wordings have changed. There, cricothyroidotomy was there. Here, it is not mentioned. You need to have an front of neck access. This is nothing but cricothyroidotomy, scalpel cricothyroidotomy. Wake the patient up. No, why you will wake it up? Because he has multiple anesthetic and you already paid. You need to have an front of neck access. You're not able to back mask ventilate. If you're able to back mask ventilate, then you will be thinking of waking the patient up. Video laryngoscopy comes in plan A. Use of bougie comes in plan A. Direct laryngoscope intubation comes in plan A. Now you are in plan D, where the front of neck access is required. After 1 hour of the medical management ABG taken, which one of the following is an indication to start an NIV? In simple terms, what is the indication to start an NIV? They're asking here. It is an COPD patients we are having. We are already aware that these are the indications for anyone who is having an COPD to start an NIV. So remember this, it's very important. Multiple times you will appear. Out of these options, this one is present here. That's why we are choosing option 1. A 57 years old patient presents with shortness of breath. The patient is hypoxic and respiratory distress. Here, observations are as follows. Severely hypoxic, tachycardia, tachypnea. You start to decide on NIV. Which one of the following is an absolute contraindication for NIV? Absolute out of this, we have discussed multiple times, upper airway obstruction. One episode of vomiting is not an absolute. Recurrent episodes of vomiting in spite of giving antiemetic is an absolute indication. Do not get confused. So this is the fixed upper airway obstruction is the right answer here. A 44 years old patient with a tracheostomy was brought to an ambulance in the ED with complaints of shortness of breath due to tracheostomy. The speaking wall is already removed by the paramedics. The patient is still struggling to breathe. The patient is received in the resuscitation and connected to the cardiac monitor. What is the most next best step? So after removing the speaking walls, what is present here, the next best step is to remove the inner tube. So the option 2 is the right answer here, to remove the inner tube. Once you remove the inner tube, then you will try to pass the suction catheter. If that doesn't work, then you will deflate the cuff. If that doesn't work, then you will remove the tracheostomy tube. So remember the sequence. Again, similar question. The speaking wall over the tracheostomy tube is removed and connected to the oxygen. No improvement is seen. What is the next best step in the management? Remove the inner tube. So remove the speaking wall or any cap is present. Remove the inner tube. Pass the suction catheter. Deflate the cuff. Remove the tracheostomy tube. Remember the sequence. It is important. It's the same thing. That's why I'm not discussing this question. Same thing to the previous one. Here we are having another question. A 29 years old male presented to the ED with complaints of pain in the right shoulder. He gives a history of the slip and fall and sustain an injury to the right shoulder. X-ray of the shoulder shows anterior dislocation. You decide to reduce the anterior shoulder dislocation using an methoxyfluorine. What is the contraindication for methoxyfluorine? Kidney disease of grade 2? No, it is not a contraindication. Hyper, no. Diabetes, no. Asthma, no. Severe adverse reaction to inhaled anesthesia? Yes, because this is also an inhaled anesthesia. So the right answer here is the second one. An obese patient with BMI of 40 presents to the ED with shortness of breath and requires intubation. The patient has a history of poorly controlled hypertension, diabetes, hyperlipidemia. Given the situation, the most appropriate next step in management of this patient is, okay, what you will do. After 4 unsuccessful intubation attempts by the emergency physicians, no, emergency physicians, 3. So this is not a right answer. Call the consultant anesthetic for assistance. No, after 3 only you need to call the anesthetic, not after 4. It is 3 plus 1. So this is the wrong phrase. Try intubation without required pressure. It is not recommended without required pressure. It is always recommended with required pressure. If you fail it, then you try that method. So this is also not a right phase, especially in a patient who we are trying to intubate. Continue attempting non-invasive ventilation. This patient clearly requiring intubation is required, so you cannot go back. Utilize an laryngeal mask airway. If your failed plan A is failed, then you will be going to using a laryngeal mask airway. Use a normal direct laryngoscopy, then you try to intubate. Arrange for an video laryngoscope to facilitate intubation. Yes, this is the right one. Why? I am suspecting a difficult intubation here. Whenever I am suspecting a difficult intubation, difficult airway trolley should be present, or the equipments which will easen for you to intubate, like a video laryngoscope, fiber optic laryngoscope, those things needs to be present. So the right answer here is the fifth one. Because of the BMI being 40, we are suspecting obese patient, difficult intubation. Obese patient will have short neck and a thick neck. According to Koch-Mac-Lehans classification, this view is classified as: you're able to see epiglottis, you're clearly able to see ocal cords, you are clearly able to see you're clearly able to see the lower structure. Also, arterionoid is also clearly seen. So this is a type 1. This one has appeared in previous diet. This one also appeared in previous diet. This one also has appeared in previous diet. So given 47 years old male with a known history of COPD presents to the ED with worsening shortness of breath, accompanied by cough, expectoration. The patient is not responding to medical management and is now drowsy. Vital parameters are given here. They are grossly okay, with SpO2 requiring and high flow oxygen. APG shows acidosis indication, PaCO2 value on the higher side indication. So for a COPD patient, we have 2 indications for here to go ahead with an NIV, because they're not responding to the medical management. The doing a rapid sequential intubation will be an overkill here. First NIV, you need to try it. Continue the oxygen saturation to support an SpO2 of, yes, but the patient, there is indication for NIV here, so you cannot just continue with the oxygen. Start continuous positive airway pressure. No, you are not starting on continuous positive airway pressure. This continuous positive airway pressure is only preferred in pulmonary edema. Remember the indication, pulmonary edema. So we have 2 options with an NIV, that is BiPAP, what we are having. One with an lower settings, one with an higher settings. We always start with a lower settings so that the patient is comfortable. Then repeat an ABG after 1 hour. If there is no improvement in ABG, then you will incrementally increase over the time. You cannot directly start with such high readings. So the best answer here is the first one. Thank you, everyone. Anyone has doubts, you can ask me.